So many of us surviving the COVID pandemic and now without masks. It's a welcome sign of relief for all of us. Just a short bit about Chronicles. This was Dr. Raju Khubchandani's brainchild last year. The science that they possess, I mean, people who have interacted with them know how good they are in their own fields. Dr. Sane, when you interact with him, somehow you remember not Dr. Vajpayee, but Atal Bihari Vajpayee. That's what Indu told me to say. Those pregnant pauses, that's what she says. Dr. Vaidya, everyone knows him, pulmonologist, very, very meticulous. And Ajit is popularly known as an encyclopedia. So we'll not delve into all that further because they've requested, they've not even sent their single slide CVs to us. So we will not talk about that further. Rules. We need to be strict about the timings so that we can have a little time for all the food that is there, which Cipla has sponsored. So we need to stick to the times, and if you don't stick to the time, then we have the timer over here. If you cross your time limit, you will not be considered for the award. So it's 3 minutes for long cases. A small beep will go out at about 2 minutes, and a long beep. Do we have everyone? And a small request to the people who are presenting musculoskeletal infections. Third case, pseudo-hypoparathyroidism. Dr. Abhishek Kulkarni Pankhuri is the presenter. And don't blame it on COVID.
Admitted at 26 weeks of gestation. The pregnancy was IVF. She had tested COVID positive around 3 weeks back. I did a gram stain of the pus. I found gram-positive bacilli elongated intracellular suggestive of Listeria monocytogenes. And in 48 hours of incubation, it's a non-fastidious organism. This include elderly, pregnant women, newborn, and immunocompromised people. Listeriosis during pregnancy may result in fetal loss and premature labor, which happened in this patient, and neonatal infection and death. It's most likely to develop during the 3rd trimester. Importantly, the dietary risk factors include ready-to-eat foods like soft cheese, hot dogs, deli meats, hummus, ice cream, yogurt. And soft cheese made from unpasteurized milk is supposed to be the incriminating agent. It's a unique pathogen because it's intracellular. CMI is the host defense against Listeria. Thank you. I can't stop abruptly what I did. Thank you.
Yeah. Can I start? Yeah. So very good afternoon. I would like to acknowledge my co-authors, Dr. Amish Vora and Dr. Sonu Udani. So this was a story of a 14-year-old boy, had a painful swelling over his right shoulder and elbow since 2 days, had high-grade fever with chills, and there was a history of heavy exercises in school camp since the past 5 days. He came in with severe tachycardia, tachypnea, all signs of compensated shock, with a severely warm, tender swelling over his right shoulder and the right elbow. He had this large multiloculated abscesses in the deltoid and the triceps, for which I did a drainage through the deltopectoral approach. A huge amount of pus was found in both the triceps and the deltoid. It was sent for microbiological analysis, which came out to be MRSA. Patient was monitored in the ICU, started the antibiotics as per sensitivity reports. But after 5 days, he started complaining of pain in the right thigh. He had a severely tender right thigh, and again the MRI showed a huge amount of pus collection in his thigh. I drained it through the lateral approach, again a huge amount of pus. This time the culture was negative because probably he was on appropriate antibiotics. Again he started doing well. Again after a few days he started complaining of pain in the back. We turned him to a side and there was a huge amount of swelling in his paraspinal muscles. And the saga continued. Over the next 13 days, I debrided a total of some 23 sites. Almost all muscles were involved. So what exactly was this condition? So this condition was known as a tropical biomyositis. This is a very invasive condition with usually single but rarely multiple intramuscular abscesses in large muscles. These are pure intramuscular muscles. The muscles overall were looking fine. It was inside the muscles. And typically seen in adolescents, after a bout of physical exertion and trauma, as was in this case, he had a kabaddi camp a few days prior. The common organism is staph. And these are very few articles which are there about tropical biomyositis. 2 of them are from India. We did 2D echo and did all the immunological workup, which turned out to be negative. I drained all sites, antibiotic for 6 weeks. I counseled the parents for multiple site involvement. Thankfully, he started recovering after 3 weeks. There was full and complete healing of all surgical sites. This is the full range of motion. And this guy came to me to give me sweets after his 10th board exam. This is after a year of follow-up. Thank you very much.
Good afternoon. I am presenting case of pseudo-hypoparathyroidism, which was recently published in a journal of pediatric endocrine and diabetes. So this is a case of 9-year-old male boy who presented with the first episode of hypocalcemic seizure. There was no significant history and no features of rickets or AHO as round face or stocky habitus or brachydactyly. On investigation, there was severe hypocalcemia. Serum calcium was just 6 with high PTH and high phosphorus. Vitamin D, albumin and creat were all normal. EEG skeletal survey were normal. So disproportionately elevated PTH levels for hypocalcemia and elevated serum phosphorus with normal vitamin D suggested pseudo-hypoparathyroidism. IV calcium gluconate was administered, which was followed by oral calcitriol and calcium supplements. The child responded to treatment and was discharged at serum calcium levels of 8.1. Clinical exome analysis by next generation sequencing yielded a novel stop-gain mutation in the STX gene. This was confirmed by Sangers, and the maternal gene analysis also confirmed the presence of same variant, which substantiated autosomal dominant maternal transmission. The patient was seizure-free and is growing well on calcitriol, oral calcium carbonate supplements and vitamin D supplements. The serum calcium levels are kept in low normal range with a normal urine spot calcium creatinine ratio. So coming to pseudo-hypoparathyroidism, they are of 2 types, 1A and 1B. The 1A is because of heterozygous mutation in GNAS gene, which is maternally inherited, and it has features of AHO with end organ resistance to other hormones also, mainly involving PTH, TSH, gonadotropins and growth hormone releasing hormone. The PTH1B on the other hand is mostly sporadic type, which is because of GNAS exon A or B methylation defects, and less common 15 to 20% can be because of deletion in STX16 gene, which is upstream of the GNAS locus, and AHO features are rarely present and the other hormone resistance are rarely there. So the pseudo-hypoparathyroidism disorders are caused by mutation or deletion in GNAS gene locus or upstream of the complex. Both alleles are expressed in the tissues except in the PCT, pituitary, gonad and thyroid, where the maternal allele is expressed. This tissue-specific allele expression is under the influence of exon A and B, which in turn is regulated by a long-range imprinting control region on STX16 gene. We report a novel heterozygous stop-gain mutation in STX16 gene, which has not been reported till date from our country. We describe an association between the epigenotype and the genotype here. The presentation follows rule which imprinting disorders follow, that if it is transmitted from a female carrier, it will cause PHP1B, whereas transmission from male carriers will not cause the disease. Also, it will not present in the neonatal period, but the PTH resistance will present from infancy to adulthood, like our child who was asymptomatic till 9 years of age. Hence, genetic diagnosis and stratification are imperative not only for molecular characterization but also for genetic counseling.
Good afternoon, everybody. Today I'm presenting a case of DRESS syndrome with COVID positive. So here's a history of 9-year-old boy who presented with high-grade fever since 11 days, progressively increasing in frequency and intensity. Generalized macular rash associated with itching and rubbery consistency, tender lymph nodes in inguinal and cervical region. On examination, child also had anasarca, splenomegaly, and tonsillitis. We involved 3 sets of investigation as a working up for differential diagnosis. First involved infection, where we did CBC, blood culture, urine culture, and USG abdomen. Second set involved viral infection, so we did COVID RT-PCR, dengue, and EBV. Second set involved reactive investigation, so COVID antibody, inflammatory markers, and 2D echo. And third was the malignancy, peripheral smear and bone marrow examination was done to rule out that. So investigations-wise, there was a rise in lymphocyte counts from 5,000 to 47,000 within a span of 11 days with lymphocyte predominance. COVID RT-PCR was positive on day 5 of illness. To COVID antibody and 2D echo was normal, X-ray was normal, inflammatory markers were borderline high, cultures remained negative, and bone marrow examination was normal. First, we started the child on empirical antibiotic, though there was no improvement with it. On day 3 of illness, the child developed hypotensive shock, which was fluid responsive, which we attributed to immune reaction because there was no rise in inflammatory markers, no cardiac dysfunction. Hence, considering it to be hyperinflammatory stage, we started the child on IVIG and steroid, to which child did respond. In 24 hours, his rash and edema started declining and fever started subsiding. Next, we got the report of EBV, which was positive with 11,500 copies, which was significantly high. Retrospectively correlating, it was eosinophilia with rash, which was mostly secondary to drug, and EBV positive. We made a final diagnosis of DRESS syndrome. To rule out a complication of X-linked lymphoproliferative disorder, we did an extended LSSA test, which was negative. So here the learning point is, even though first we thought it to be a viral infection where we got a COVID positive, RT-PCR positive, the child later on behaved like a hyperinflammatory stage wherein we did start the treatment considering it to be reactive, to which the child responded. We rule out malignancy also, but later on everything came down again to another viral infection, which was EBV and the complication associated with it. So hence, we should not put everything on COVID. Thank you.
Do we have any questions from the audience or judges for any of these 4 cases?
Hello.
Mic is not working.
Yeah. When it comes to DRESS syndrome, by definition, it is a drug-induced story. So, which was the drug involved in this? Which was the suspected drug? Hello.
Sir, a third generation cephalosporin was started for the child before coming to SRCC.
Acha, I didn't note that. Okay. So the reason, another thing is that even with a diagnosis, what you did was you withdrew methylprednisolone, right?
I can't hear you, sir.
Hello? Yeah, sorry. So you withdrew methylprednisolone and you continued IVIG.
So IVIG had already gone. We had given 2 gram per kg, and by the next day where we got EBV, we were continuing steroid, so that we stopped. But IVIG was already gone.
Okay. So what difference did it make in terms of your diagnosis, apart from withdrawing steroids?
Sorry, sir?
Did the prognosis differ in any way by diagnosing it as a DRESS syndrome?
So DRESS syndrome, because it fitted in the picture, and the other thing was we had to stop steroid because it was EBV positive. It would have lead to flare up of the infection and other complication.
Yeah, that's a point well taken. But if you were not positive, would you have continued methylprednisolone?
Yes, sir, because there was clinical improvement.
So clinically, actually, diagnosis does not really change the management, right? Just a comment.
But here, stopping steroid...
because of the EBV, not because of the
EBV.
DRESS syndrome diagnosis.
No, sir.
Anyway, thank you. That was an interesting.
So may I just make a comment? So the steroids were given because we thought that the child was having an inflammatory response. We didn't know at that time what the inflammatory response was due to. But because this inflammatory response was so strong, causing hypotension and making him sick, that is why the steroid was given as a pulse dose. The moment we got the EBV is when we started to decrease the steroids after that.
Can I ask a question? My question is to Dr. Mandar, and I just wanted to ask that if such a case comes to you again, kind of would your priority of investigation change if such a case comes to you again? Because this child
Yeah, so
this was a very, very rare presentation. In treating so many hospital infections in pediatric age group, I have never had a child who presented with so many infections at the same time. Probably the nature of abscesses was completely different in this case. That may have made me look for other sites. Here the abscesses were completely intramuscular. You
I mean, I just have one question for Shaheen. It is not related to the case. It's a very interesting case of listeria, which we think is not very common in our country. So that was very interesting. But I just wanted to know, as a microbiologist and as a clinician, the prophylactic antibiotic used in the pregnant woman was augmentin. Is that really a good idea, or what are the flip side of that?
Judges, can I request you to come in the front so that I think since the sound system is creating issues, we can have the questions directly over here. We go on to section 3 now. We have chylothorax. Dr. Rohit is presenting that.
Hello. Check. 1, 2, 3. Hello.
Good afternoon, everyone. I'm Dr. Rohit Bide, DNB resident at SRCC Hospital. I'll be presenting chylothorax as an unusual manifestation of a novel syndrome on behalf of all the names that you can see on the screen. So this was a 3-month-old previously healthy boy who presented to us with acute progressive dyspnea and generalized puffiness of 2 weeks duration. On examination, he was found to be tachypnic with subcostal retractions. His air entry was reduced on the left side with a dull percussion note. He had dry and hyperpigmented skin, anasarca, and moderate hepatomegaly. On admission, we did a chest X-ray, which was suggestive of left-sided pleural effusion, and a USG thorax confirmed the same. We did a diagnostic pleural tapping, and milky white pleural aspirate was tapped, which had pleural fluid triglycerides of 224 milligrams per DL, diagnostic of chylothorax. So considering his age of 3 months, the first differential which we had in mind was congenital, namely lymphangiectasia and lymphangiomatosis, traumatic or surgical causes, but there was no history suggestive in this scenario, or a high central venous pressure because of SVC thrombosis, tumors, and miscellaneous causes. So we did a workup. We found deranged lipid profile, pleural fluid analysis suggestive of high pleural triglycerides. We wanted to do a lymphangiography and lymphoscintigraphy, but because of anatomical limitations, that could not be carried out. He had raised D-dimer levels. Genetic studies was done on this child because he had a history of sibling death in the previous child who had similar complaints, but the cause of which was unknown. So routine workup was done, CBC and urine routine, and endocrine workup for hyperpigmentation. So he had nephrotic range proteinuria with hypoalbuminemia, primary adrenal insufficiency, hypothyroidism,
and hypogammaglobulinemia. So meanwhile, we got the genetic testing reports, which was suggestive of sphingosine 1-phosphate lyase 1 gene mutation, SGPL1 mutation, suggestive of nephrotic syndrome type 14. So this SGPL1 loss of function mutation is mainly associated with 5 findings: steroid-resistant nephrotic syndrome, adrenal insufficiency. These are the 2 most consistent ones: ichthyosis, neurological deficits, and immunodeficiency. So the main challenge here was the nutritional loss via urine and chyle. We started him on low-fat, high-protein, high MCT-based diet, replacement therapy for endocrine issues. Enoxaparin was started at prophylactic dose for high D-dimer values. A repeat USG thorax showed only a minimal pleural effusion, and child showed clinical improvement. So this unusual presentation warrants more insight into this mutation. Whether the chylothorax is directly associated with this mutation needs to be figured out. A long-term and close follow-up would be done for this case to see the progression of disease. And this is the first reported case in India, and child is currently stable. Thank you so much.
Good evening, everyone. This is a case series of mineralizing angiopathy of childhood. This was the 14-month-old boy. He was a second child of a non-consanguineous marriage with normal development history. One day he was playing around when he had a fall on the right side, and thereafter he was unable to sit or stand. He then presented with weakness in the right upper and lower limb with facial deviation. There was no loss of consciousness. So he was taken to the emergency department where a CT scan was performed. So these were the CT scan findings. On a plain CT scan of the brain, we could appreciate these well-demarcated calcifications which were seen in the basal ganglia region on both sides. In addition, we could see this tiny gliotic focus in the head of the caudate nucleus, which suggested that he had had a previous stroke. Then there was an MR which was performed to confirm the finding of stroke, where we found restricted diffusion in the lentiform nucleus and the adjacent corona radiata region. This stroke, the infarct was well evolved because we could see it was hyperintense on T2 and hypointense on T1. On the gradient images, we could see these tiny areas of blooming which corresponded with the areas of calcification in the basal ganglia. And the 3D TOF angiography was plumb normal. There was no abnormality seen in any of the large vessels. The next case was a 5-year-old girl who slipped and fell while playing. The next day, her parents noticed that she was refusing to use her right hand and she had become clumsy. She had started to trip while attempting to walk or run, and she also had slurring of speech, a change in behavior. Hence, she was taken to the hospital. On examination, the neurologist found that she had hemiparesis and an upper motor neuron type of facial palsy with decreased tone. So a CT brain was performed, where again, we found these well-demarcated areas of calcification in the basal ganglia on both sides, along with a hypodense area in the basal ganglia. This was the MRI findings of restricted diffusion with a well-evolved stroke. Angiography findings were normal. So a comprehensive workout was performed for both these children, including 2D echo, thrombophilia profile, as we do in a stroke patient. All of them were found to be normal. The children were treated with aspirin and antithrombotics. Now, what was notable was that both these children had a characteristic basal ganglia stroke following a fall, with basal ganglia calcification on CT scan. Now, what we know are the causes of basal ganglia stroke in children, such as vascular malformations, vasculitis, and central causes. But there was this entity called trauma and bilateral basal ganglia calcification, which was considered a distinct entity which we now know is mineralizing angiopathy of childhood, and it accounts for about 2% of strokes, where the key abnormality is the mineralization of the lenticulostriate arteries. But why does it occur in infancy is because there is an acute angle between the middle cerebral artery and the lenticulostriate arteries. This angle becomes more obtuse as the age advances. During trauma, the mechanical forces cause rapid brain displacement and excessive stretching, which causes atheroma formation and arterial stroke. So what we now know is that an infantile stroke after minor trauma with basal ganglia calcification should prompt this possibility of mineralizing angiopathy, and in such typical cases, we can then avoid the extensive etiological workup so that we save time and cost. Thank you.
Should I begin? Yeah. Good afternoon, everyone. With this short presentation, I wish to emphasize the importance of use of genetics in the management and the treatment course of diabetes presenting in infancy and the impact it has on the natural course of the illness. At the onset, I would want to thank my guide, Dr. Abhishek Kulkarni sir, for making me a part of the team managing the case. So, a 26-year-old male with a birth weight of 2.2 kilos presented to us in the casualty with a blood glucose of 684 milligram per DL. He presented with severe ketoacidosis, and on investigating the HbA1c was diabetic. The C-peptide levels was low, and the conventional autoantibody panel consisting of GAD, islet cell antibody, IA2 insulin, and insulin antibody were negative. The DKA was managed initially using intravenous fluids and intravenous insulin. Transition to subcutaneous insulin was made once the DKA resolved. The therapy was done using long-acting insulin once a day at a dose of 0.2 unit per kg per day, whereas short-acting insulins were given 3 to 4 times a day, only if the pre-feed HGTs were about 200 to 250 mg per DL. To avoid glycemic excursion and to time the short-acting insulin, the feed was predetermined and express breast milk was given and ad libitum feeding was avoided. Initially, the TDD varied from 0.8 unit per kg to 1.1 unit per kg per day. Now, since the presentation of diabetes was within the first year of life, Sanger sequencing of select genes were done, which depicted a mutation in the KCJN11 gene. So, on follow-up, the child was discharged, and on follow-up, the insulin requirements progressively kept coming down, and at 4 months of age, the child was completely euglycemic with a HbA1c of 5.4, and the insulin requirements were negligible, with pre- and post-feed C-peptide which were detectable, suggesting remission. Insulin was discontinued, and the parents were explained that there was 50% chance of recurrence or relapse in adolescence or adulthood. Now, at 7.5 months of age, the child was again evaluated, and at that time itself, the child was euglycemic without any treatment, and the development was normal. What this case tells us is that neonatal diabetes mellitus can be of the transient variety. It's a rare form of monogenic diabetes, and it can be either due to overexpression of 6q24 locus or due to genes encoding subunits of voltage-dependent potassium channel. The learning points in this case are that very small insulin dose requirement, high risk of hypoglycemia, lack of subcutaneous fat for insulin administration, and to coordinate the timing of the feeds and insulin is very, very challenging. Though the initial management is with insulin, either via MDI or CSII pumps, later on, the child can be shifted to oral hypoglycemic agents depending on the type of mutation that is detected. So the learning point of this particular case is the importance of genetic in management of the case, because the child can come off insulin completely for some time at least. Thank you.
Hello, good evening everyone. I'm Dr. Shruti. I'll be presenting a rare case of plastic bronchitis in a 1-year-old child, and my co-presenter is Dr. Rajesh, who's not here today. So we had this case in emergency, 1-year-old boy with a no significant birth history and normal development, who had a history of cough and cold for 1 month on and off and was symptomatically being treated over phone during COVID times. He presented to the ER with a history of sudden onset excessive bouts of cough. He had fever and fast breathing. When the pediatrician saw him, he had fever, he had tachycardia, tachypnea, decreased chest movements on the left side with decreased air entry, and on percussion, the note was dull. So the differentials which they came up with was a left-sided pneumonia, left-sided pleural effusion, or foreign body aspiration and mucus plug. So first they did a chest X-ray which showed opacity or a whiteout lung on one side of the lung with left upper lobe showing some aeration and obliteration of the costophrenic angle. They did a bedside USG to rule out the empyema or the effusion, followed by doing a CT scan which showed a classical cutoff sign, and there was a collapse in the middle lobe and the lower lobe. That is when they thought that maybe we are dealing with a foreign body aspiration, and I was called. So when I did the scopy, what I saw was that there was no obvious foreign body seen in the trachea or the bronchus. However, in the left main bronchus, there was some secretion and whitish discharge. So I thought it is a mucus plug. We did a bronchoscopic extraction of this, and what came out was really surprising. For a moment, I thought I'm extracting out worms from the patient, but it came out and it was floating. This is a situation which is known as bronchus plastica. We do not have a video because it was done through a rigid bronchoscopic extraction. This is the this is a video which I have taken through my bronchoscope to just show you the left main bronchus, which now shows the cleared bronchioles. And there were a lot of these tree-like or branching clasts which were seen. This is a post-op X-ray of the child which was taken 48 hours after the procedure, and bilateral air entry was equal. So my take-home message is that the bronchus plastica is a very rare condition, but it can be acute, life-threatening respiratory failure can be caused. It is characterized by formation of thick mucus plugs that can cause airway obstruction. It can mimic a situation like foreign body aspiration or even status asthmaticus. Bronchoscopy in such cases can be both diagnostic as well as therapeutic, and it must be performed urgently in case of severe obstruction. Also, bronchoscopy extraction is extremely difficult in these cases because these casts are really stuck there, and sometimes we also need to go transtracheal to extract such casts. So I leave you with this message that plastic is difficult to extract wherever it may be, either bronchus or your oceans. Thank you.
Request people from section 1 to be ready. Do we have any questions for these cases? We have one.
So fast that the calcification will happen so fast that as soon as the fall happens, that there is a stroke. Mineralizing angiopathy of childhood.
Team?
How fast does the calcification occur?
So ma'am, in these cases, the calcification is already pre-existing. They have a mineralizing angiopathy. So the vessels are already calcified. And then when they have a trauma, that predisposes them to develop a stroke. If like to add anything. But it is because the vessels are calcified, when they have a trauma, there's a shearing force between the lenticulostriate arteries which causes the atheroma formation. And then this lenticulostriate artery typically gives rise to this basal ganglia stroke. So as our neuro team also highlighted for us, is there any other? Yes, sir.
Just a comment.
Yeah.
Just a comment. Whenever you see, first of all, 1% of CTs will show you basal ganglia calcification as a normal variation. Somebody seems to have ignored the stroke along the. Now, if you see calcification in a setting like this, you will always think of a group of entities called interferonopathies. This becomes very important. This is part A. Part B, a spontaneous stroke like this, if this child were an Agarwal, I would please request you to do ADA2 enzyme levels. Otherwise, he will land up with another stroke.
Thank you so much. So this mineralizing angiopathy as an entity has been described in Indian subcontinent population. It's a very new entity, has been described from India, around 100 cases in only 2014. The thing is, we really haven't delineated the pathophysiology. What comes first, the calcification, when there's a stroke. But it is a clinico-radiologic entity as of now. We do not have the exact cause for it. So it occurs in a children 18 to 5 years of age. They have this trivial trauma, just a fall while walking or a fall from the sofa, which a child may have any day. And then they come with this sudden stroke. And that is because of the lesion in this basal gang, basically at the site where it is due to the lenticulostriate arteries infarct.
I just have a question.
So, sir, more studies need to be done. There is only one case series that was published. Rest all were cases that were published. And in the case series that was published, they only found some association with iron deficiency anemia. But again, iron deficiency anemia in Indian children is really the cause or not is a whole thing that will need more studies, more meta-analysis.
That's what I was trying to say, that iron deficiency anemia is a notorious association with spontaneous strokes after a trivial fall.
Yes, sir.
So here, how would you know if there is mineralization, is that always the cause or that mineralization?
So that's the whole thing. It's an entity in progress, very frankly. Whether iron deficiency is or not associated is not known. But the recent IAP neurology guidelines on stroke which are being written say that if you have a child who is like this, who has a trivial fall and you see basal ganglia calcification, you might look for iron deficiency anemia, but you need not look for all the other causes of stroke that are there. No need to spend tens of thousands on the thrombophilic profiles.
Did your patient have iron deficiency anemia?
One of them had, one was completely okay.
And also, sir, in the first child, there was a gliotic focus in the caudate nucleus, which suggested that he must have had a stroke before also, which probably went unnoticed. So they do have this mineralizing vasculopathy, which is predisposing them to probably get recurrent strokes.
So is this treated like an adult stroke with any antiplatelet agents or anything?
I think
to avoid a further stroke?
Yes, antiplatelet agents are given for a period of year or two, but they haven't been, as I said, very new entity, they haven't been said, like, is it the standard, gold standard treatment for it or not yet.
But I guess it prevents them from getting another stroke, and that is what leads to a good outcome in these children when they are treated with aspirin and antithrombotics. Otherwise, the mechanism of mineralization, it just prevents the atheroma formation, which will occur because of trivial trauma, right? That is what is causing them to stroke, the atheroma formation. So that will be
just
prevented.
To avoid the platelet plug, that's it.
I have not question for you, but I have question for another Mr. Gill, for the transient neonatal diabetic mellitus group. And I think your case was excellent. But the key message I didn't understand. You said that the key message is that the genetics make this management of this case very easy, whereas when you presented, it was a clinical decision to stop the insulin when the child became later.
Yes.
So how can you
So neonatal diabetes is of two types. One is the transient variety and one is the permanent variety. Around 50% of the cases are that of transient variety. So what genetics does it helps us to stratify whether the child can be shifted from subcutaneous insulin after remission to oral hypoglycemic agents. Like there are some KCJN 11 mutations, ABCC 8 mutations, which are amenable to oral sulfonylureas like glibenclamide. But in our case, before starting the glibenclamide, the levels had already gotten to normal, so we never needed to use the oral therapy. Though there can be recurrence later on in adolescence or adulthood, the insulin requirement might be present, but for a significant period of time, the child can be on no insulin, no medications, or only oral sulfonylureas. So that sort of helps us classify whether it's just transient or whether it's permanent. And the quality of life of the child improves in the sense that you don't have to use insulin therapy. Thank you, sir.
We go on to section 1. The first case, the presenters are still in the OT. We go to the second one, a curious case of dysgerminoma, followed by AHD syndrome, and then a case report of strep pneumonia. Please be ready, presenters.
Good afternoon, everyone. I'm Dr. Priyank Rajan. I'm going to present a curious case of dysgerminoma today. So we had a 13-year-old female born of third-degree consanguineous marriage presented to us in April 21 with secondary amenorrhea lasting for 12 months and abdominal distension for 3 months. The family history was significant of infertility in maternal aunt and uncle. On examination, her stature was appropriate for her genetic potential. Her gonadal development and pubic hair was of Tanner stage 4. On abdominal examination, we found a firm, painless abdominopelvic mass. The USG showed a right adnexal solid cystic lesion, 12.5 centimeter. The MRI showed a normal uterus, a pelvic lesion, and peritoneal deposit, along with an enhancing lymph node of around 8 mm. Tumor markers were raised, suggestive of increased AFP, beta-HCG, and serum LDH. Also, FDG PET scan was performed, which was suggestive of increased uptake. So at this stage, we had two differentials in mind, malignant germ cell tumor and a dysgerminoma. So we sent out a constitutional karyotyping, and to our surprise, it was a 46XY karyotype in a phenotypically normal female. So endocrine evaluation was done, which was suggestive of raised LH and FSH with hypoestrogenism, suggestive of hypergonadotropic hypogonadism, leading to gonadal failure. The genetic testing for disorders of sex differentiation was normal. On the treatment front, we started initially with 2 cycles of chemotherapy, which included bleomycin, etoposide, and cisplatin, followed by response evaluation with AFP and beta-HCG. The assessment for metastasis was normal, followed by surgery, which comprised of exploratory laparotomy and bilateral oophorectomy, and the remaining 2 cycles were given. So it was a dysgerminoma of stage 3 as per FIGO staging. So the histopath was suggestive of dysgerminoma-like cells in the right gonad, so that's suggestive of gonadoblastoma. The left side is streak ovary with Carl-Exner bodies with a pathognomonic of dysgerminoma. The peritoneal fluid was also showing tumor deposits. So to summarize my case overall, she's a 13-year-old female with secondary amenorrhea, with normal external female genitalia, with normal uterus, with no signs of hyperandrogenism or virilization or clitoromegaly, with ovarian gonadoblastoma, having a karyotype of 46XY, thus diagnosed as Swyer syndrome. Her current status is she's on disease surveillance with tumor markers well within normal limits. She's on hormone replacement therapy for bilateral oophorectomy. So the main takeaway home points I would like to say is always send a constitutional karyotyping in an adolescent female presenting with secondary amenorrhea and suspected germ cell tumor. And also during surgery, if there is a streak or a non-functioning gonad, do remove the gonad, keeping in mind the current recommendation of preservation of the unaffected ovary. Thank you so much. Also, I would like to thank the great team of consultants who made it possible for the child to live a normal and a healthy life.
Good afternoon once again. Now I'll be presenting the case of a thyroid insensitivity syndrome, which is very rare, called the Allen-Herndon-Dudley syndrome. I would again begin by thanking Dr. Abhishek Kulkarni sir for giving me the opportunity to present this case. Now, a 1-year-old male presented to us in the OPD with severe developmental delay and thyroid dysfunction in the form of high free T3, low free T4, and normal TSH levels. The weight of the child was less than 3rd centile, length was between 10th to 25th centile. There was axial hypotonia, spastic quadriparesis, dystonia, more so in the oromandibular region, the trunk, and the limbs. The face was elongated with cupping. And the major finding here was that the resting heart rate was somewhere between 100 to 120 beats per minute, as confirmed on 2 occasions. Now, since the picture was that of developmental delay depicting central hypothyroidism, but there was peripheral toxicosis features. Hence, the child was investigated, keeping in mind that this could be a thyroid hormone transporter defect at the central level. On investigating the reverse T3 levels done by LCMS were low. There was increased catabolism peripherally as depicted by higher SHBG, higher lactate, and higher ammonia levels, which confirmed our suspicion of peripheral toxicity. Now, our doubt was confirmed by again doing a WAS analysis, which revealed hemizygous single base pair duplication in exon 1 of the SCL16A2 gene. The boy's mother was found to be a carrier of the same variant. This genetic defect is X-linked recessive. The MRI depicted delayed myelination and cortical atrophy. Now, treatment was begun in collaboration with Erasmus Medical Center, Rotterdam, and a new novel drug called triiodothyroacetic acid, or TRIAC, was started on an individual off-label basis, and the primary therapeutic target was to achieve normal levels of free T3. What this case tells us is that MCT8 is a specific thyroid hormone transporter in the brain. The mutation that was found in the WS analysis causes defect of this particular transporter. The biochemical hallmarks of this condition are elevated free T3, normal or low free T4, low reverse T3, or slightly elevated TSH levels. Now, there are multiple types of mutations. Both deletions and missense mutation all cause severe psychomotor retardation. And the hallmark, again, is central hypothyroidism, but a state of peripheral thyrotoxicosis. Now, with the new novel therapy, there is amelioration of thyrotoxic features, but now they found out that the myelination can also improve if the treatment is begun early within the first 2 years of life. So that is a major benefit of this particular drug, though a separate study is still under trial. Now, the possible benefits of free T3 assay in addition to TSH and free T4 when a child presents in the OPD is very, very important, especially in cases with severe intellectual and motor disability. Because if we had not done free T3 assay in this particular child, we would have just labeled the child as central hypothyroidism, and this was a completely different mutation. Thank you.
So I'll quickly present a rare case report of Streptococcus pneumoniae in a case of septic arthritis in a neonate. Septic arthritis presents challenges regarding clinical diagnosis, workup, and definitive management. The predominant causative organism is Staph aureus, and it commonly affects the hip and knee joint. Urgent management is needed, so treating surgeons must efficiently work through differential diagnosis and identify the concomitant infections and do a timely irrigation and debridement. I would like to present a normal full-term vaginal delivery child, 45-day-old female with swelling of the right knee and thigh with inability to move the legs and excessive crying and irritability for 10 days. This child had mild fever and knee swelling, for which she was taken to local facilities at the outskirts of Mumbai, where it was diagnosed as transient synovitis and given anti-inflammatories. The child's condition didn't improve and presented with established features of septic arthritis and osteomyelitis of the right distal femur. The MRI showed abscess extension in the right suprapatellar bursa through a defect in the anterior cortex of the distal femur and also osteomyelitis. Arthrotomy and debridement was done and 20 cc's of pus was sent in a Bactec bottle. So blood culture bottles help in the enrichment of pus and quick growth of organisms, and in our hospital we've got this culture of sending pus in blood culture bottles and even sterile body fluids. So on gram stain I saw gram-positive coca in pairs, flame-shaped, elongated, suggestive of Streptococcus pneumoniae, typically in pairs like this. On sheep blood agar, the colonies that grew were alpha hemolytic, that's greenish with incomplete hemolysis. Sensitivity pattern showed it to be sensitive to penicillin, cephalosporins, fluoroquinolones, but resistant to erythromycin and cotrimoxazole. Earlier, cefazolin was given, but it was changed to cefotaxime as per the susceptibility, and then started on oral augmentin for 6 weeks. The patient is at present under evaluation. So, to discuss this, strep pneumoniae causing arthritis is rare. After the era of vaccination, incidence is less than 1%, and can cause infections in unimmunized patients. After routine vaccination, these bacteria are no longer detected in children less than 5 years of age. I'm presenting this case because getting strep pneumonia from arthritis and osteomyelitis in the neonate is supposed to be uncommon now, and we grew it. Thank you.
The first case, we have the surgeons, they've come out from the OT finally. Section 1, case 1.
Thank you. Good evening, everybody. I'll present the first case followed by Dr. Anju. We have a set of interesting cases. My case is a 4-month-old girl child, who first presented in 2018 with a history of redness, watering, discharge, irritability. It just didn't look like a regular conjunctivitis or a nasolacrimal duct obstruction, which we expect at age 4 to 6 months. So we took the child up for examination under anesthesia, and this is what we found. We found funny-looking pseudomembranes. We've seen pseudomembranes before. We actually sometimes just peel them off or separate them from the tarsal conjunctiva with a blunt glass rod. These pseudomembranes were thick, fibrous, could not peel them off easily, could not separate them off from the tarsal conjunctiva very easily. We didn't really know what we were dealing with. We started with antibiotics and steroids. It did improve some, which is the second picture, but nothing really great. At some point, we decided to take off a little piece and send it for histopathology. The clinical picture and the histopathology findings suggested ligneous conjunctivitis. The membrane structure, the woody, thick, fibrous membranes on the tarsal conjunctiva fitted just into that. Unfortunately, we did not have a way to do plasminogen levels, which would have been ideal. Because of the steroids, the child developed steroid-induced glaucoma. We had to deal with all of that. Each time we would touch the conjunctiva, we would have a flare-up. So we chose to treat the child with fresh frozen plasma, intravenous, each time we touch the eye, and we make fresh frozen plasma eye drops every 15 days for this child. We referred the case to Sir, Dr. Kupchandani, for evaluation of the systemic condition, and we know that respiratory tract is involved in ligneous. Fortunately, this child did not have involvement. I'll pass on the case to Dr. Anju.
Thank you. So a similar looking case, which was a 4-year-old female with a positive history of consanguinity, came to the airway department. She presented with this kind of supraglottic granuloma which was obstructing the airway, and she had a tracheostomy in situ. On examination, her conjunctiva, nail beds, all showed similar kind of granulomas which were at different stages of healing. Considering a systemic disease involvement, we referred this case to Kupchandani sir who, considering the previous case of Legionnaires conjunctivitis, having similar fibroinflammatory granulomas all over the body, he first thought that this could be another similar case of Legionnaires conjunctivitis. However, on deep probing, and this time he took up into his own study that he did a complete genetic examination of this child, and we came out with this new condition, a very rare one, which only 50 cases have been reported in the literature. This is an autosomal recessive disease called laryngo-onychocutaneous syndrome. Now, this is a very rare disease which presents something similar to what the Legionnaires conjunctivitis picture was, but also involves the respiratory system, the nail beds, and sometimes dental conditions also are seen. Surgical intervention in these cases are repeated microlaryngoscopic examination and removing these obstructive granulomas with laser, applying mitomycin locally, and then hopefully this child can be decannulated. However, considering the negative prognostic factors present in these kind of children with a very short lifespan, this case was referred to a geneticist on request of the parents. Dr. Shruti Bajaj, she undertook this case, and she found a phenotypic-genotypic correlation in this case. Considering the positive family history in two of her paternal aunts who are showing favorable prognosis, she feels that if we find out a correlation that she is of a milder variety, then we can offer this kind of repeated surgical interventions and hopefully decannulate this child. So the further research is on, and hopefully we'll have answers soon. Thank you.
Thank you. I invite Dr. Indu Khosla, who also was in the OT incidentally. She will take us through the longest cases.
Thank you, Amin. Without much ado, I will invite the first 4 people who are going to present to us the longest variety. Just to give you a reminder that it is for 6 minutes, followed by question-answer session. The first lot, the expanding spectrum of COVID pathologies, protocol-driven management of cleft lip and palate, renal complications of Wilms tumors, outcomes in bilateral Wilms tumor, and the last is role of MRI in pediatric. Is that there, or it's okay? So these 3 are there. So these 3, please. The first presenter, the expanding spectrum of post-COVID pathologies, please.
So good afternoon all. I am Dr. Ritika Garg, presenting the case expanding.
First of all, if it's a 45 days old baby, it will move to qualitative neonate, because then the risk factors for neonate and streptococcus pneumonia will be different. And secondly, I was not very happy with this augmentin as a choice of antibiotic in strep pneumonia, because augmentin has no role for streptococcus pneumonia resistance, as we know, is by taking penicillin binding protein and not by penicillin secretion. And therefore, I think that 2 points actually did help.
Yeah. So about this 45-day-old child who came, was symptomatic around 2 weeks prior to when the patient came to SRCC and was getting treated at other places at the outskirts of Mumbai, and that's when the pathology developed, and therefore we labeled it as a neonate. But I agree with you. As regards augmentin, I agree that the addition of clavulanic acid doesn't help here because it's not an ESBL producing organism. But I understand that even like with that listeria case, the sheer availability and the use and the experience that they have with augmentin pushes clinicians to use it more often as compared to ampicillin. But maybe also because my culture sensitivity report had mentioned augmentin also as sensitive. I shouldn't have probably given it. That could have also driven the clinician to use augmentin.
Dr. Devika, we have conventionally been told that T3 is less important as a marker of thyroid function, right? So is that a take-home message from your case that we should be doing 3 every time?
So what was emphasized and what we are trying to report is in children with psychomotor disability of unknown etiology, it's worthwhile to include free T3 while doing the conventional FT4 and TSH. By no means are we trying to emphasize here that free T3 should be a part of routine evaluation of primary hypothyroidism. Its role is limited to delineating thyrotoxicosis. And that's why when we wrote this paper, we have categorically emphasized that by no means are we trying to bring in free T3 in newborn thyroid screening. It is only when you're dealing with psychomotor disability of unknown etiology, it can obviate the need for expensive investigations, and detecting the condition prior to 2 years of age has significant improvement in neurodevelopmental outcomes. I'll take the opportunity for clarification for Dr. Sane's query. We were lucky in that neonatal diabetes, that diabetes remitted by 4 months of age. The usual course may vary between 3 to 18 months, and hence genetics is crucial because genotype-phenotype correlation tells us which one will remit, which one will not. Secondly, many of these are on oral sulfonylureas the moment we see amenable mutations. So the course of transient diabetes is also much smoother, and insulin pumps can be avoided in early infancy.
Good afternoon. I am Dr. Ritika Garg, presenting the case of expanding spectrum of post-COVID pathology. So basically we are presenting a case of 14-year girl who was apparently developmentally normal with complaint presented to us with complaint of fever, abdominal pain and vomiting for 4 to 5 days. Initially she was got treatment on OPD basis and was not relieved. And she developed decreased oral acceptance on day 3 of illness, for which she was hospitalized. At admission, her vitals were stable, but she had increased work of breathing. And on primary investigation, her blood sugar levels were high, 650 milligram per deciliter, and she was severely acidotic with pH of 6.9 and bicarb of 2, with the urine ketone of 4+. So she was primarily diagnosed and managed as severe DKA, initially with the IV fluid, and IV insulin started at 0.1 unit per kg per hour. On day 2 of illness, she developed drowsiness. Parallelly, she had hyponatremia. So drowsiness was attributed to hyponatremia with sodium level of 119. So for that, she received 3% saline, although the drowsiness persisted even after correction of sodium. So she was referred to SRCC hospital. At presentation to us, she was hemodynamically stable but with poor GCS. With GCS of 5/15, pupils were mid-dilated and sluggishly reacting. She was intubated and ventilated. Although there was no obvious cranial nerve deficits or no focal neurological deficits, neck rigidity was there and poor cognition. And she was not aware of her surroundings and she was drowsy. Initially we kept a possibility of cerebral edema along with the DKA with the fluid mismanagement. So we treated her as DKA with cerebral edema. On investigation, we found a component of hepatitis with bilirubin of 4.5, SGOT-PTs were raised in 6,000s, and sodium was 162, which was attributed to iatrogenic component. And that time CRP and procalcitonin were also high, 14 and 6.9. So initially we were dealing with the cerebral edema, and she had seizure also at day 4 of admission, which were attributed either to hyponatremia and meningitis, for which we were giving 3% saline and mannitol along with the neuroprotection. For the to prove the meningitis, we did a CSF analysis which shows 10 cells and sugar protein were almost normal. MRI brain and EEG brain was also done, which showed triphasic waves. And to look for the hepatitis, one cause was either it is of multi-system involvement, sepsis induced, or viral hepatitis, for which viral markers were sent, or it could be of autoimmune etiology, for which autoimmune panel including the LKM antigen and SLA antigen was sent, which were negative. And USG abdomen was done to look for the echogenicity and texture of the liver, which was also normal. For sepsis point of view, she was having high-grade fever with high TLC and high procalcitonin. IV antibiotic were obviously started and upgraded. And DK point of view, she was on already on IV fluid and IV insulin and treated as per the end opinion, which was gradually settling down. MRI was done on the day 1, which as we can see, which shows the T2 hyperintense lesion in the basofrontal and basotemporal areas, and also in the midbrain and pons. The similar lesion seen in the globus pallidum and the splenium, as we can see here. These lesions show restricted diffusion. The lesions in the frontal lobe and the basitemporal lobe show restricted diffusions. There was no obvious enhancement or the enhancement in the films as we can see, and spinal MRI was grossly normal. So based on MRI, our primary differentials were it could be the infectious etiology with the bacterial or tubercular, for which workup was done and was negative. CSF cultures was negative. Second was either demyelination or autoimmune, although autoimmune CSF panel, including the NMDA antibody, NMO-MOG, all were negative. Third, it could be either inflammatory or vasculitis, as these changes can be seen in vasculitis. So at that point of time, we thought of COVID antibody or MISC. COVID antibodies were done, which was positive, 9.5, which was reactive. And we, after that, we get MISC panel or the inflammatory panel, including the serum ferritin, D-dimer, and procalcitonin, which were high. So that time, we started the child on IVIG and MPS, for which child apparently start recovering, and our working diagnosis was of post-COVID MISC with DK with encephalopathy. In view of prolonged intubation with poor GCS tracheostomy was done, repeat MRI and EEG was done. EEG showed diffuse slowing of the wave, and she was hypotonic and limbs were not moving. So for that, we got NCV done, which show critical care neuropathy. She was extubated after tracheostomy, feeds were started and hiked up. There was not much improvement in the cognition. She was still E2, VT and M4. At discharge, she was on tracheostomy, although recognizing mother. Right facial palsy with aphasia was persisting. She was hypotonic with quadriparesis, on full RT feeds, and for DK point of view, she was started on subcute insulin. Physiotherapy and oromotor therapy were continued. So our take-home message is MISC is a unique clinical complication of SARS-CoV infection in children. Patients with MISC have a good outcome when they are treated with the IVIG and corticosteroids. For patients with MISC and post-inflammatory condition, we suggest monitoring of blood sugar levels and vigilance for development of acidosis or ketosis. And children parallelly present with neurological manifestation may overlap with the cerebral edema and DK as in our case. In our case, the child was having both cerebral edema as well as the neurological manifestation. And the management of such patients is supportive. Thank you.
Good evening, everyone. I'm Dr. Sujata Ravlani from Department of Anesthesia, and my topic of presentation is Protocol-Driven Management of Cleft Lip and Palate Surgery, Enhanced Recovery and Improved Outcomes. Cleft lip and palate are one of the most common craniofacial abnormalities seen worldwide with a very high prevalence. They are subdivided into unilateral and bilateral. Smile Drain is the world's largest cleft focus organization, which provides 100% free cleft surgeries. NHSRCC Children's Hospital is a proud companion of this global movement. We have successfully managed 195 Smile Drain cases, which includes 130 cleft palate, 56 cleft lip, and 9 others, which includes alveolar bone graft and palatal fistula repair. Preoperatively, the most important factor remains the patient selection, which is based on age, weight, and hemoglobin. We include all patients under ASA 1 and 2. Any child with a history of recent URI is deferred for 4 weeks. And these patients usually present with many comorbidities and difficult airway. So a thorough pre-op evaluation is mandatory. Here comes the most important part of parental counseling. We explain the parents about plan of anesthesia, different modalities of pain management, and give them strict written and verbal fasting orders, which is 6 hours for solids, 4 hours for breast milk, and 2 hours for clear liquids. We explain them about the surgical technique, duration of surgery, and risk involved. And of course, we need to tell them what to expect after the surgery. The surgeon inserts a nasopharyngeal airway post-operatively, which not only acts as a conduit and helps the child breathe, but also helps in facilitating expulsions of the secretions. We also apply bilateral elbow splints, which avoids the manual removal of the nasopharyngeal airway by the child himself. In the preoperative area, we take a written informed consent, and after confirmation of blood RAE tube, which is a preformed south pole tube used in head and neck surgeries for better surgical exposure. This is the classical positioning given for all children posted for cleft repairs. We put a small pillow below for the maximum head extension. The AT tube is supported with the underpad, and also a roller gauze is kept at the chin level, and the tube is fixed using a tegaderm. Standard Asm monitoring is done for all children. During throat pack insertion and application of the Digman gag, we have to be very vigilant, and all our eyes are on the monitor to see any rise in the peak airway pressures because of the compression of the tube by the gag. If so, we need to communicate with the surgeon so that he can help us by adjusting it. We maintain the anesthesia using injection dexmedetomidine, which not only gives us nice, better hemodynamic stability, but also useful for preventing emergence delirium. The fluid of choice remains lingalactate, and other drugs which are used are injection dexamethasone, which decreases the airway edema and has an additive antiemetic effect. Injection tranexamic acid to reduce bleeding, and injection magnesium sulfate, which is an excellent bronchodilator. For pain management, we adopt a multimodal approach where we use injection fentanyl, diclofenac suppository, injection paracetamol, and give bilateral maxillary nerve block. It is relatively a new block, and we give it under USG guidance. Many studies have been done to compare maxillary nerve block with palatal blocks, and it has been found that maxillary nerve block is superior. In our department, currently we are doing an RCT where we are seeing the efficacy of maxillary nerve block for postoperative pain relief in these cases. You can see a diagram which shows the anatomical landmarks of the needle insertion and also the ultrasonic view of the anatomy. To make things clear, I'll show you a small video where you can see anteriorly there's the maxilla, posteriorly there's the sphenoid, and in the pterygopalatine fossa, you can see the maxillary artery pulsating, and here is the drug depositing at the correct place under USG guidance. Before extubation, always confirm removal of throat bag and generation of adequate tidal volume. Oxygenation in the postoperative area is done using a T-piece on the nasopharyngeal airway. Postoperative monitoring is done, and a designated nursing staff is being assigned to every patient. Early feeding is promoted. We are on our toes to deal with all the anticipated complications until the patient is shifted to the ward. Thus, at every step of our management, we incorporate enhanced recovery after surgery components for better clinical outcomes, decreased postoperative morbidity, complications, length of stay, and decreased need of opioids. Thus, we can conclude here that a protocolized approach to patient management is associated with improved outcomes, as out of 186 patients, only 2 needed re-exploration because of bleeding, and rest went home happily on post-op day 2. With adoption of multidisciplinary multimodal approach, we continue to spread smiles till date. Thank you.
Hello, everyone. I'd like to present the renal outcome and renal complications and short-term outcome in bilateral Wilms tumor, a case series. So it's a multidisciplinary team effort involving Dr. Sajid Qureshi, Dr. Uma Ali, Dr. Rasik Shah, Dr. Amit Nagpure, the PICU team, and the hemato-oncology team from Tata Hospital and SRCC. So bilateral Wilms is a very rare entity and accounts for only 4 to 7% of all the Wilms tumor. It is especially challenging in the management because we are trying to achieve a good cure rate by complete removal of the tumor, while at the same time trying to hold on to as much of the renal function as we can. Ours is a case series with 15 patients of bilateral Wilms who were operated at SRCC from November 2017 onwards. So this graph is for the age of presentation. As you can see, when these Wilms tumors are commonest in the first 5 years. In that, we've had our maximum patients, 8 out of 15, who were in the 13 to 24 month age group. The youngest was 9 months and the oldest was 52 months. In the gender distribution, there is a female predominance with 10 out of 15 being girls. Regarding the time of occurrence of the tumor, 13 out of 15 were synchronous and 2 out of 15 were metachronous. In the associated extrarenal features, we found that some of the children had ambiguous genitalia, one had ventricular septal defect, one had optic atrophy and corneal opacities, that is a Peters syndrome, one had bilateral undescended testes, and one child had hypospadias with bilateral undescended testes. Now coming to the type of surgery that was done, the options were either a unilateral nephrectomy with the contralateral nephron sparing surgery. Majority of them, that is 7 out of 14, underwent that. There was bilateral nephron sparing surgery, where 6 out of 14 underwent, and one child alone underwent a bilateral nephrectomy, becoming anephric after this. If we look at the rising levels of the creatinine in the post-op period, it was noted that the maximum increase in creatinine was seen within the first 3 days of post-operative stay, in which the create level went to more than 3 times the baseline. But at the time of discharge, which is typically 2 weeks from the date of surgery, it was seen that most of the children had less than a 1.5 times increase in creatinine. If we were to correlate this to the estimated glomerular filtration rate, almost all children preoperatively had a very good GFR of more than 90 ml per minute per 1.73 meters square. In the post-operative period and at the time of discharge, a large number of them still continue to have a very good glomerular filtration rate. One of them was below the range of 15 ml per minute per 1.73, but that was because of being in the anephric state. If we look at the hypertension perspective, 9 out of the 15 children were hypertensive preoperatively, and 13 out of 15 became remained hypertensive post-op. However, they were well controlled with one drug. Also, we noted that there was a strong evidence of hypoalbuminemia which occurred in the post-operative period, with almost 8 out of the 14 children having a 20 to 50% drop in the albumin levels, and that of which 4 of them had to be given albumin infusions because they were presenting with persistent drain leak, which then recovered after albumin infusions. So what I would like to summarize is that 87% of our children survived, and so far none of them are on renal replacement therapy. Of course, we will need long-term follow-up to understand their long-term outcome. Bilateral Wilms, if you see globally, does not have a very favorable outcome, with the reported cure rates approaching 80% in the best centers, but they're usually less in resource-poor settings. Bilateral Wilms needs a multidisciplinary approach for diagnosis and treatment, and they definitely benefit from surgery in centers where there is excellence in all the departments and who have maximum experience in treating the same. Thank you.
Floor is open for questions. Any questions from the judges or anybody in the audience? Yeah, Dr. Sane. Yeah, COVID, okay. The talk on COVID, yeah. Yes. Yes, sir. Yes, sir. In our, sir, this case was in January only, and it was IgM. Although there was no
There was no history of as such COVID positivity in the child, but family members, one of the family members was positive, so we thought of she was asymptomatic in that phase, and now she's presenting with COVID positive antibodies, which was IgM. And this case we saw 2 months back only in end of December and January, starting of the third wave, sir.
This is an observation, not necessarily a question. In a couple of MICs, I have seen post-treatment hyperglycemia. How often do you see that? And during COVID also, we've seen a lot of decays, unusual number of decays in our hospital.
Yes, sir.
Yes.
So I'll take this as I was managing the case with the ICU team. So throughout these 2 years or more, we've seen hyperglycemia during an acute infection because of the virus binding to the angiotensin converting enzyme 2 receptor. That is your acute viral illness, ACE binding, beta cell destruction, but not complete. Hyperglycemia may remit or may evolve into diabetes. What we have more commonly seen is hyperglycemia due to probably autoantibody, SARS-CoV-2 antibody, like we saw in this case, the IgM1 as a part of MISC, or very rarely the long COVID with antibody-mediated viral facilitation into the beta cell. So those acute destruction and antibody-mediated viral dissemination into beta cell may be classified into transient or permanent. So this is COVID-related hyperglycemia. We still do not know whether it will stay back as diabetes. But so far, cases reported across the globe, autoantibody-mediated ones have been insulin dependent. And their conventional autoantibodies that we do in type 1 diabetes, they're all negative throughout the course. So probably autoantibody-mediated destruction behaves in a similar way like type 1 would, and these patients would stay insulin dependent, whereas viremia-related hyperglycemia could be transient or permanent, depending on the extent of beta cell destruction.
Any other question? Anybody from the audience? Thank you so much, dear. I just want to remind you that you audiences are also, we have our esteemed judges. Of course, they are our guests, and they're really going to do a good job, and I can make out by the number of questions that they're asking. But all of you also have to judge, and we would be looking at your judgment too. So now we go on to the next lot of the longest cases, and from here we have from 0 to infinity, not hero, from 0 to infinity, mineralizing angiopathy of childhood. I think that is already over. So malignant hypothermia triggers anesthesia and a cry for dantrolene. Then interesting case of an exemplary diagnosed fetal pelvic cyst and its management.
Good evening, everyone. I am Dr. Anushka Prabhudesai, Fellow Pediatric Rheumatology under the guidance of Dr. Raju Khubchandani. And I would like to take you through the journey of our child from 0 to infinity through a rather hair-raising tale. A 7-year-old girl started developing patchy hair loss. There was no associated fever, rash, or any other constitutional symptoms. This caused her a great amount of social and emotional distress. She would cover her head with a scarf and was very reluctant to go to school. The local dermatologist diagnosed her as alopecia areata, and she was started on twice-weekly levamisole. There was some but not complete hair regrowth, and she was very regular with her treatment. But about 1.5 years later, the hair fall started increasing tremendously. In addition, she also developed fever, joint pains, and oral ulcers, and was hence referred to the rheumatology department. When we examined her in our OPD, we also found short stature and bilaterally symmetrical hallux valgus. So we asked for a skeletal survey, which showed bullet-shaped vertebrae. The child had come to us with these reports, which suggested that all 3 cell lines were low. There was Coombs-positive autoimmune hemolytic anemia and low titer ANA positivity. So here we have a child with consanguinity, though it was distant. There was short stature, bullet-shaped vertebrae, and bilateral symmetrical hallux valgus, which suggested some form of skeletal dysplasia. The autoimmune hemolytic anemia, positive ANA titers, along with the whole symptom complex, suggested autoimmunity. So all this led us to think about monogenic lupus, especially one that is caused by SPEN-CD, which is spondyloenchondrodysplasia. And so we sent her genetic studies, but this is what we got. This is brachyolmia type 4, which is a form of mild skeletal dysplasia. Now this explained all her skeletal findings, but her autoimmunity was still not explained. So we reflected further. We had our brainstorming sessions in the OPD. And then one fine day, we had our eureka moment. And we thought that, hey, this child has been on levamisole and she's been taking it like regularly for over a year. This is an immunomodulatory drug. And we remembered having read about associated autoimmunity. So we read further. And there were a number of articles on levamisole-induced autoimmunity and vasculopathy. We stopped the drug and only kept her on topical pimecrolimus for the alopecia. After 4 months, the response was almost magical. There were no systemic complaints. The labs showed improvement in all 3 cell lines, ESR normalized, and the Coombs turned negative. But the alopecia continued. We consulted our pediatric dermatologist, Dr. Manish Shah. He initially started with topical steroids and oral zinc for 4 to 6 weeks, but the alopecia continued. So then we switched to oral DMARD, methotrexate, at 12 milligram per square meter body surface area, and there was slow but steady increase in her hair growth. And after 6 months, you have yourself to see that she had a head full of hair. So after all this, it was a drug. So our learning point here is that when a child is on a new drug or long-term therapy or multi-drug therapy, it is prudent to rule out drug-induced causes before jumping to disease complexes or rare syndromes. Regular monitoring is important not only for the disease activity but also for the drug side effects, especially while on long-term therapy. As the saying goes, wonder drugs. One really wonders what they will do next. Which brings me to some more hair-raising tales. We have seen a sulfasalazine-induced SJS, phenytoin-induced rugger jersey spine, nifedipine causing gum hypertrophy, asparaginase-induced thromboembolism causing gangrene, phenytoin-induced dress syndrome, etanercept causing psoriasiform rash. Now to elaborate on all that, I would require another session, maybe next Chronicles. Thank you so much for your patient listening.
Good evening, everyone. I'm Dr. Venetia, and my topic for today is malignant hypothermia, triggers, anesthesia, and a cry for dantrolene. Central core disease is an autosomal dominant neuromuscular disorder characterized by features of congenital myopathy. It presents in infancy as hypotonia, motor developmental delay, and a non-progressive muscle weakness more pronounced in the hip girdles. In 25% of the cases, it is associated with malignant hypothermia. MH has an incidence of 1:5,000 to 1:50,000 to 1 lakh. Earlier, the mortality with malignant hypothermia was 70 to 80%, but it has reduced to less than 5% with the availability of dantrolene and capnography. We present a case of a 4-year-old male child with CCD posted for right hip open reduction and acetabuloplasty. Child had history of developmental delay, both motor and speech development, failure to thrive, and hypotonia. Genetic testing advised by the neurologist showed a heterozygous missense variation of the RYR1 gene. Child had no previous exposure to anesthesia, no family history of complications related to anesthesia. Routine investigations and creatine kinase were within normal limits. Hence, a trigger-free anesthesia was planned. Parents were informed about the risk associated with anesthesia and the non-availability of dantrolene in our institute. It was planned as the first case in the OR. Vaporizers from the anesthesia machine were removed, soda lime canister was refilled with fresh soda lime, and the circuit was flushed with oxygen before wheeling the patient in. Anesthesia was induced with fentanyl, propofol, and muscle relaxant atracurium. Airway was secured, following which an NG tube and Foley's catheter was inserted to aid in core cooling in case of MH crisis. This is the picture of an anesthesia machine with vaporizers removed and a freshly refilled soda lime canister. Arterial line was secured and an epidural catheter was inserted. Standard Asm monitoring including ECG, pulse oximetry, capnography, and NIBP was used. In addition, invasive arterial pressure, core temperature, and urine output was monitored. Total intravenous anesthesia was used for monitoring. Oxygen and air along with a propofol infusion was used. Pain management was done by epidural infusion. Intraoperatively, the temperature remained between 35.3 to 35.9 degrees Celsius. Warming blanket was used, which was then turned off when the temperature approached 35.9 degrees Celsius. There was no significant change in EtCO2, PaCO2, or pH levels as seen by serial blood gas analysis. Patient was then reversed and extubated uneventfully, following which he was observed in the PACU for 2 hours and then shifted to the ward. Patient made full recovery and was discharged from the hospital 2 days later. So what is malignant hypothermia? It's a pharmacogenetic disorder of skeletal muscles that presents as a hypermetabolic response to volatile anesthetic agents such as halothane, sevoflurane, desflurane, and succinylcholine. It may occur in the first exposure to anesthesia, but some patients may require up to 3 exposures to have an MH crisis. It can occur either during or in the early postoperative period. The signs of MH include tachycardia, rise in EtCO2, muscle rigidity, hypothermia, respiratory and metabolic acidosis, and if untreated, this can result in hyperkalemia, myoglobinuria, acute renal failure. So how can this be prevented? Avoiding use of trigger agents, use of activated charcoal filters as shown in the picture to absorb any residual volatile agents. TIVA and regional anesthesia is preferred. Monitoring to include neuromuscular monitor and BIS to ensure adequate depth of anesthesia. A high level of suspicion and a constant monitoring of temperature and CO2 levels is needed. MH cart should include dantrolene, sodium bicarbonate, calcium chloride, disposable cold packs, and other emergency drugs. Supportive treatment includes discontinuation of the trigger agents, hyperventilation, cooling with IV saline, external cooling. Dantrolene. It is the fundamental drug for the management of malignant hypothermia. Specific RYR1 antagonist that inhibits the calcium release from the sarcoplasmic reticulum. It's given in a dose of 2.5 milligram per kg and it's titrated to the clinical signs. However, it's an expensive drug with limited availability and a shelf life of just 1 year. Dantrolene was not available in our institute and efforts to procure the drug were futile. In this patient, we were aware about the genetic condition and the risk of MH, hence we avoided all trigger agents. However, there are many patients with similar presentation who do not undergo genetic testing. So use of trigger agents in these children could lead to catastrophic events. Though supportive measures may mitigate the symptoms, they may not lead to definitive recovery. So the Malignant Hypothermia Association of United States recommends that dantrolene should be available at all locations where trigger agents are used. So what is the MH scenario in India? Pillai et al. Reported the 7th case of malignant hypothermia in the year 2015. However, this may be underreported due to the lack of national registry, lack of genetic testing, non-availability of diagnostic tests, economic constraints, and most importantly, a common misbelief that it doesn't exist in our ethnicity. So it is time we stop being the ostrich in this scenario. The need of the hour is to increase the awareness amongst anesthesiologists of the risk of malignant hypothermia. Dantrolene should be available at institutional or regional levels to ensure timely administration. MH hotline and national registry should be set up to report cases of MH. Despite knowing about malignant hypothermia and its lethal potential, does its rarity make it ethically appropriate for us to administer anesthetic services without any access to dantrolene? And another interesting fact, the same case after 2 months will be posted again for the surgery of the left side, and yet we do not have any dantrolene available for the patient. Thank you.
There's one slight change. There's one more longest which has come in, and it is incidence and variation of neuro-COVID among the waves.
Good evening, everyone. I am here to present incidence and variation of neuro-COVID among the waves in a pediatric population. To introduce this is a retrospective observational study from the Department of Pediatric Neurology with the Department of Intensive Care Medicine and support from our Department of Radiology. We aim to analyze the presentation, management, and outcomes of patients with COVID-related illnesses from a single center. Our inclusion criteria are patients who presented with new onset of neurological symptoms, patients who had exaggeration or a new onset of neurological symptoms with an existing underlying neurological disorder. All the included patients had laboratory evidence of COVID RT-PCR positive or an antibody reaction. Our exclusion criteria was children who did not require admission or patients who had simple febrile seizures with either RT-PCR or antibody positive. So, moving to the results, we can see the demographics of 47 patients here. The blue line here represents our national spectrum with respect to rise and fall of our COVID waves. The green line is the total number of patients with COVID positive who were admitted at our center. The red line represents the patients who came with neurological symptoms of the same. If you observe closely, every wave that we have is followed by the small little wave that we attribute or want to attribute to the antibody did not. We had respiratory, GIT, mucocutaneous, endocrine, cardiac symptoms, and renal symptoms. What is noteworthy here is that the cardiac and mucocutaneous symptoms were present with antibody positive patients much more than the antigen positive patients. We want to attribute these patients to the MISE sort of picture where we have the cardiac, the rashes, and other inflammatory markers. For the lack of time, I am not going into the details of the biochemistry. We have the MRI reports of all our patients were done, which were suggestive of microhemorrhages, encephalitis-like pictures, the acute necrotizing encephalopathy of childhood that we can see here. We had patients who presented with stroke, both arterial and venous, patients who presented with demyelination as a form of the Morg spectrum disorder. We had patients who presented with basal ganglia hyperintensities. These were patients who also presented with the movement disorders. We had patients who were presented with tuberculomas. Normal TBM granulomas with basal exudates were found in 8 of our patients. We had normal MRI for 15 patients. There was one patient that we could not categorize into anything, and we've just labeled her as a diffuse changes. EEG was suggestive of background slowing in the form of encephalopathy. epileptiform discharges, and normal EEG was also found. So there was no one specific EEG marker for COVID. Treatment, if we observe the treatment, we find that the ventilator, inotropes, the steroids, immunomodulators, and antithrombotic drugs, that was not a part of the regular CNS treatment. We find that they were maximum present with wave 2. In the first slide, we saw that the number of patients were maximum in wave 3. So we here want to point out that the patients requiring intensive care were more in wave 2 than wave 3. So we can conclude that wave 2 had a worse neurological impact on our patients rather than wave 3, which had a maximum number of involvement. If we want to categorize the outcome in form of no deficit, neurological deficit on discharge, or death, we had 2 deaths in our cohort. One was in wave 2 and one was in wave 3. Both these patients had underlying TBM granulomas, if we find the reason. Wave 2 has the maximum number of patients going home with some neurological deficit, which sort of relates to the treatment graph that we just saw. The neurodeficits that we found on discharge was in the form of cranial nerve palsies, aphasias, seizures, movement disorders, or hemiparesis. To conclude, COVID-19 in children has a varied neurological presentation in children with the maximum incidence found in wave 3. The prevalence of neurological symptoms was maximum in wave 3 in the form of seizures, encephalitis, hemiparesis, movement disorder, peripheral neuropathy, cranial nerve palsies, and headache. Patients with underlying TB infections presented with an acute exacerbation in a COVID-19 related illness. And while wave 3 had a maximum number of cases with neuropresentation, most of our patients had an uneventful hospital course with a good clinical recovery. Thank you.
Question answer session. Any questions from the audience, from our esteemed judges? Yes, Dr. Thyroid.
So this is to the presentation about malignant hypothermia, and this is something which is non-negotiable, and I think we must have it at least in our city, if not institution. And what can be done is you have an association of pediatric anesthetists, because the adult anesthetists will not be interested in this. I have lost a child 15 years back, because of malignant hyperthermia, and we could not survive the child. And if we had dantrolene, I'm sure that child would be done. So, if you are planning to operate that child, don't do it now, since you know that the child can get malignant hyperthermia, and make it available. I know, it's difficult, but you can make it available through people who import dantrolene. I also know that after 6 months, if it's not used, you may have to discard it and keep on replenishing it. But I think it should be available, and we are happiest if you don't have to use it. But in case if you need, and if you cannot use it, we will feel very sorry. So, your comments on that. Pardon? Yes, yes. So it is not even 0.5% of GDP of SRCC Children's Hospital. So we should make it up. Yeah. It is less than canteen bill of all the doctors put together per month. I'm just giving, so it is something which we can get. Very simple. It's the problem is people, it's not available in chemists. And if it has to be imported. So you will have to give this order. I'm sure anesthesia department would have done some research on that. Yeah, Nandini, you're the right person.
So we've already gone up to the medical director on this. So initially I was told that, it doesn't happen, and we've managed without dantrolene. But we know the fact that we can have patients dying on us. And So there are people who import it. It's available only in the grey market. It costs about 20,000 per vial. And I would look at it as an investment we never have to use. So it's about 60,000 insurance, if you may. But I need all your support in this because it looks like we are the only one crying for dantrolene. The last time it was on us, do you want to do the case or cancel? You know, that kind of thing. That kid is coming again on Tuesday. We still don't have dantrolene. I'm calling Sarika every week to say, get it done, get the sanction. Yes, sir.
If you're doing even 5 surgeries a day, and you have 180 surgeries a month, and in 6 months, in which time the vial dies, you've got about 1,000 to 1,500 surgeries. Amortize the cost over that. Tomorrow it's time to pay advance tax. Look at it as a surcharge and be done with it.
Thank you, and looking towards all your support. Thank you so much.
There's one more case pending in this session, which is the interesting case of antenatally diagnosed fetal pelvic cyst and neonatal management.
Good evening, everyone. This is a joint presentation of the Fetal Medicine Department, SRCC, with the Pediatric Radiology, Neonatology, and the Pediatric Surgeons. So we had Mrs. ST, a low-risk primary gravida, who came to us at 12 weeks. She was registered. The first trimester screening was low risk. Anomaly scan done at 19 weeks was unremarkable. Everything was fine. At 30.5 weeks, the fetus was showing 2 cystic areas in the pelvis. This was a pear-shaped area just below the bladder. And how did we say this is the bladder when we put the color signal? 2 umbilical arteries on each side of the urinary bladder. And the cyst was below and behind the bladder with no vascularity. So the next thing we saw was the gender, and it was a female external genitalia. The size of the cyst was 3.6 and 2.4 centimeters, and of course we had to see the baby from head to toe. The GUT, the small bowel, large intestine, stomach were absolutely fine, the kidneys were fine, the liquor was normal, and the growth was fine. The next important thing which we would like to see in this case is the perianal muscular complex. So we can see a target sign, that is the hypoechoic area with the echogenic center, which is the lumen. So this rules out complex cloacal abnormalities associated with pelvic cyst in a female fetus. And of course, the cyst was very close to the sacral spine. And we had to ensure that there was no tethering of the cord, the entire spine was fine. So this cyst was basically jammed between the bladder in front and rectum behind. So on ultrasound, if we see a cyst in a baby, it has always a differential diagnosis, and we boil down based on the location and the appearance of the cyst. And nowadays, a good paper in 2019 said that male gender and female gender, and they divided the cyst according to that. And majority of them were found to be ovarian cyst in the female fetuses. So in view of the gestational age, that is beyond 28 weeks, the location in a female baby, pelvic placement of the cyst, we gave a differential, that is hydrometrocolpus or hydrocolpus, which may or may not be a part of a complex urogenital sinus abnormality or a persistent cloaca, though it was less likely because it was a very clear cyst with no other ascites features or other thing. Posterior position of an ovarian cyst, intestinal duplication cyst, and very unlikely a sacral meningocele. Sacral meningocele in a fetus has been reported in the year 2010 in the White Journal, and this was very similar to the ultrasound picture. However, we could not find any association between the neural canal. The couple was counseled in detail. The option of fetal MRI vis-a-vis was given, but they declined any invasive testing, no fetal MRI. And we explained them that the fetus has to be seen every 4 weekly, specifically to see any poor prognostic markers such as echogenic contents, which could be pointed to a urogenital problem, increase in the size of the cyst, and other abnormalities which can be evolving. So the follow-up was done, baby was fine, the findings remained.
There was no communication with the sacral spinal canal was seen, and the uterus was normal. So based on this finding, we gave possibility that it could be either a giant Gartner cyst, which is seen in relation to vaginal wall, or it could be rarely a duplication cyst, though we were not considering as a first possibility. And the last possibility was obstructive hemivagina with hydrometrocolpus.
Dr. Rakesh. And then so the baby was handed over to the pediatric surgeon.
Hi. Before I continue with this presentation,
One comment on the management here. Indu Khosla, Amin Kaba, and the administrators. You can't have a Saturday evening meeting with all these bottles lying here and no one can drink. It is so not fair. Completely not fair. Now, coming to the case. Coming to the case, now this child, the cyst was thin-walled, number one. Number two, it was placed between the rectum and the vagina. And number three, it was compressing the rectum. So we couldn't have waited. So we were just wondering what to do and what approach to take. So one was, of course, we have to do a cystogenitoscopy and identify what the situation is, and then maybe a laparoscopy. So we counseled the parents that we may need a laparotomy or a laparoscopy, and we may try something from the perineum also. So all gamut of consents were taken, which is not fair, I think, on hindsight. So we went with cystoscopy. So we put in a scope, and there was a bladder base which was completely elevated on the right side. So it was phenomenal. We said, Eureka, that's it. We have to just go, put in a laparoscope, and get the cyst. We will not be able to get the whole cyst out, but at least if we could de-roof it, marsupialize it, and put a drain there, and then the whole thing could take care of itself. But when we did laparoscopy, you can see the top slides. There's no evidence of cyst. Is there a pointer? Thanks. It's too close for comfort. Anyway, it doesn't matter. The top left-hand side, you can see the uterus. Sorry. What's happening? Go ahead, go ahead, go ahead. It doesn't matter. Dump it. Everything looked fine. There's no bulge in the pelvis at all, which is the point. Top one. That's the uterus. That's the ovary. That's the other ovary. It's going automatically. Ah, dear. What a shame. Technology at its work. That's the rectum. That's the uterus. That's the bladder. One ovary, other ovary. There's no evidence of cyst. So what we decided, we pulled up the uterus a bit here and saw inside. There's nothing. You can see proper pouch of Douglas. So there is no evidence of cyst at all from the abdomen. So at one stage, we thought that we'll start dissecting between the uterus and the rectum and go and hit the cyst there. Then we decided, let's go for a cystogenitoscopy. So we went with a scope into the vagina. And voila. Here we found a nice bulge on the right side, a small cystic lesion on the left side. And that's the cervix. That's the bingo is the cervix. Bullseye. So what we did is we put in a needle into this, okay, and we aspirated some straw-colored fluid. Sorry. Was that it's over now? Oh, so sorry. You give me some grace time, yeah, because I made a statement on you. That's why I'm shortening my time, I think. So this was the aspiration. This was aspirated, and we found some straw-colored fluid, and then that needle, we advanced it and it started nibbling and making a big de-roofing incision on the right. Oh shit. It started. Sorry. Okay. So you can see the last one there. The right side. We made a nice big incision, and we could enter with a scope into that hole. And the left one, we just aspirated. It was a very teeny-mini one, about 1.5 cc of fluid in it. The fluid didn't show anything remarkable. The wall was sent for histopath, which was suggestive of flat cuboidal epithelium and stratified squamous epithelium. It goes like Wolffian duct remnant cyst is what I would say. And this was, I think, the first time in so many years of practice I've done something transvaginal in a newborn child. Thank you for your attention.
I would just like to conclude, sorry we are out of time, but this is the first antenatal presentation of a Gartner cyst, So far, we were never including Gardner's or a simple vaginal cyst in our differential diagnosis. And from this case, we have learned a lesson. So we give not all vaginal cysts in a baby are unfavorable outcome. We can assure the patients, and definitely we would look forward to publish this case as well. Thank you.
Any questions for the last case? So we are moving on to the last session of the longest. I think this longest session stands between you and the food, and the SRCC management has taken cognizance of the fact that alcohol is only displayed. Maybe next time they will do something about it. Yeah. So the last lot, we have a series of about 5 cases. One is Save the Hip, a tale of 2 avascular necrosis of hip in children. A case series of unilateral hypoplastic lung, myopathy masquerading as recurrent pneumonia, COVID-19, a player or noisy spectator, a heartbreaking dilemma, CD55 deficiency and hyperactivation of complement, angiopathic thrombosis, and protein-losing enteropathy, Chapel disease. So I request the first Dr. Avisha, to present the first case.
You name it, oral prednisolone, everything was given to him for 2 months. And this is what he came to me. That is how his X-ray looked. His head was destroyed, avascular, hip subluxed, and severe pain. So when he came to me, his blood reports pretty much all the time, CRP and ESR were mildly elevated. White counts were normal all the time. He's had a lot of antibiotics and all the medication which I spoke about. So it did not fit into the things that they were showing. And I thought it is something else. So look, his cultures were also normal from the previous surgery. So luckily, I sit right next to Dr. Khoopchandani, and whenever I have googly cases like that, I just go knocking on their door next door when things really don't seem to add up. So when they went deeper in the history, they found that he did have some similar complaints when he was 3 years old, but it resolved on his own. They found nail bed pitting, so hence they thought that it could be a psoriatic type of condition which is affecting the hip. So our 2 diagnoses were Apla syndrome, causing a catastrophic hip condition, or a destructive arthritis secondary to psoriasis. So his hip range was very painful. So I was in a dilemma, do I really salvage this or I just let it be? No, but I am a hip advocate, so I went in, I operated this child, put the hip back in with all our new hip preservation techniques. Our rheumatology team really helped us. They got antiphospholipids and all their other battery of tests done. Rest of them were normal, but we still found antiphospholipid tests to be positive. So we finally have a diagnosis after 3 months of this child suffering that he has Apla syndrome. They started him on Ecosprin from their side, and from my side it was bracing and therapy and slowly giving this child some life. So actually the prevalence of AVN in these patients is really not known. And sometimes these things can be missed. As the local treating surgeons, once he went into systematic information, they completely neglected the hip. So we should not do that. So now this was him after 3 months. We kept him non-weight bearing, and you can see how great his range of movement is. He's completely painless, and he can at least have some form of life. So this was his image. So I know this hip is not going to life a lifetime, and I don't even promise that to my patients. But I know this will last long enough till he's older so that I can do much better surgeries which will last him a lifetime. So we know hip replacements are not so great in young patients. The results are not so great. They are inferior. Though newer techniques now are there to give encouraging results, but still we are not there yet. So a second case. This is a 17-year-old girl. She has JIA since age 7 and on treatment. She is very poor in her follow-up, did not take her medications properly, and she's been under Dr. Khoopchandani's care. She's taking steroids on herself since 2 years. She's referred to me in clinic with severe pain in both her hip joints. Her right side is really stiff compared to the left. She's unable to sit cross-legged, kneel. She's not able to walk more than 30 minutes and has a lot of exertional pain. So on examination, her right hip movements are quite severely restricted. The left ones are now starting to cause her problems. So the Harris hip score is 42. So the Harris hip score is a functional score which we use for daily activities of the hip. So about their staircase, their sitting, climbing. So that kind of gives. So it is not that we treat the X-ray, but we want the function of the child. So this is her X-ray. So the X-rays basically showed, you can see there is almost complete reduction of the joint space on the right side. The left side is following suit. You can see sclerotic changes in the head. This is her MRI, which shows avascular changes. And this is her ultrasound, which showed synovitis and fluid inside. So I went in and with a newer hip preservation surgeries, this is what we do. This is a percutaneous surgery called decompression, and we give intralesional bisphosphonates, unlike the oral and IVs, which have been given since quite few years, but they have not been proven in young children, but given in adults. So we know that these give good results. So post this, at 4 months, her range is excellent. Pretty much her right hip and left hip have symmetrical movements. And you can see now her joint space is also starting to improve on the right side. And it is looking almost similar to the left side. So we know corticosteroid-induced AVN is 9 to 40%, and 10% of them end up having total hip replacements. There are conflicting conclusions regarding the dose of steroids in children when they are in the setting of avascular necrosis, because a lot of these rheumatology patients will be on steroids at some point in time. So AVN, as per a lot of studies, AVN sets within the first 6 to 8 months after the initiation of steroids. The risk increases by 4 to 6% of every 10 milligram per day increase in the therapeutic dose that you're giving these children. So do not neglect the hip while you're taking care of the other things. There are multiple studies of giving bisphosphonates and treating this in adult population, but none so ever in pediatric population. So the whole rationale of giving it intralesional is, we know that 50% of the drug is excreted through the kidney outside. So the only 50% of the drug remains inside, which does not give enough the desired concentration we need. So hence nowadays we go intralesional right till the source. So in conclusion, AVN warrants early interventions in the young. Do not neglect the hip. Keep screening the hip all the time when they are under your care. I know the eventuality is total hip replacement, but my job is to prevent that till the child is adult and no longer comes to the children's hospital. The aim is to give pain relief, salvage the hip, and delay arthroplasty. With all these newer techniques, newer biologics, and the team which we have here, we can surely give successful results to all our children. Thank you so much.
Yeah, good evening all. So I'll be speaking on case series of unilateral hypoplastic lung. These are my co-authors, and that's me. Today's objectives are, I'll be discussing very few rare cases, 2 common cases. And the idea is to show you the imaging findings, and each case will have their own take-home messages. So the first case, it starts with left lung. So this is a 10-month-old child who came with cyanosis, and the oxygen saturation was 79% at room air. Echo was done in suspecting cardiac problems, and there was HAPVC of the right pulmonary veins. HAPVC means hemilateral anomalous pulmonary venous communication. The LPA also was not visualized, and the patient had pulmonary hypertension on echo. So evaluate this finding further. The CT scan was advised, and these are the representative CT scan images. What you can see here that there is volume loss on the left lung that we can see here. The RPA branches were normal, but there were very diminutive, very small size of the LPA branches. And you can see that the lung parenchyma also was lesser in volume. Incidentally, we also found we have this kind of special airway reconstruction technique in which we could see that there was narrowing in the left main bronchus that we can see here. Simultaneously, the patient also underwent cath image, and these are the representative images of the CT and the cath, in which we are seeing that that is the anomalous right pulmonary veins, which are draining into the SVC and into RA. So instead of LA, the pulmonary veins are draining into RA. That is not normal for the child. And these are the subsequent pulmonary arterial phase and the venous phase images, in which we can see that left side arteries we can see, but there is no opacification of the pulmonary veins. So there were absent pulmonary veins. So based on this finding, we made a diagnosis of pulmonary venous atresia with that hemianomalous pulmonary venous communication. This is extremely rare case in which you can find this condition. And Dr. Supratim brought this case to us, and there was multimodality discussion on this, that whether to treat right lung or not. And because it was the only lung which was getting all the blood supply from the body and heart. So ultimately it was decided that the component of that hemianomalous pulmonary venous communication, that we have to properly divert into the left atrium, so that the flow to the right lung is less and the pulmonary hypertension can be relieved. Right? So the Warden's procedure was done, and PA-PVC rerouting and ASD patch repair was done. So the patient has come to follow up to Dr. Supratim, and the patient is doing well. The oxygen saturation is 97%, and the surgery area also looks good. So that was very rare case. And generally this kind of patient with pulmonary venous atresia, they present with recurrent infection and pneumonia. And the treatment includes either you have to do pneumonectomy for the pulmonary veins absent, or you have to do reimplantation of the pulmonary veins. And in this kind of scenario, MDCT is the important investigation. It gives you single stop imaging that give you all the information. My next case is lost in entangled pipes. So this 1 year, 9-month-old child who came with outside diagnosed as sequestration in right upper lobe and lower lobe. So that was kind of fishy. You don't have sequestration in multiple lobes and all. That was slightly odd. And the patient had recurrent wheezy and noisy breathing. So that wheezy and noisy breathing bronchoscope was done outside, which was like kind of inconclusive. It was showing some multiple areas of narrowing and all. So to evaluate further, CT was done. And now you can see that these are the CT airway images, in which you can see that patency of the right upper lip bronchus. There was rudimentary bronchus, which was known as cardiac bronchus. And you can see that left main bronchus is small. But surprisingly, the right lower lobe bronchus, it is arising from the left main bronchus. So this is also a very extremely rare condition, which is known as a bridging bronchus that we have seen. So whenever you see bridging bronchus, sometimes there will be anomaly in the pulmonary artery also, which is known as pulmonary arterial sling. So you are seeing that the LPA, it is causing posterior to the left main bronchus, and by that it is compressing the bridging bronchus. But that's not the end. This patient had multiple other findings. So what we can see here that in the right upper lobe, there were this kind of tortuous systemic arterial feeders which were supplying in that area. And there were this kind of dilated pulmonary veins which were draining into the left atrium. So it was kind of pulmonary fistula in which the artery supply was from the subclavian artery, and it was draining into the pulmonary vein. So this also was confirmed on cath lab images. Here you can see that these are the systemic feeders from the subclavian artery, and there is a tortuous, these collaterals, and which is draining into a pulmonary vein. So it is behaving like a systemic artery to pulmonary vein fistula. Right, so this is also extremely rare condition in which you are having bridging bronchus, you are having pulmonary sling, and you are having sequestration not sequestration, but a fistula altogether. Extremely rare. You cannot find this kind of cases in the literature. Hardly I have seen only one case which mentioned about this thing. So the plan was to embolize that arteriovenous malformation and to correct the pulmonary sling so that the compression on the bridging bronchus is relieved. The patient has been counseled, and this patient was referred from Dr. Indu ma'am. So again, bridging bronchus, this entity is extremely rare, and CT is the modality of choice because CT can accurately tell you that where is the true carina, where is the pseudo carina, and CT will give a roadmap to the cath angio before the procedure of doing that embolization. They can give a rough idea that from where to go and how to embolize. The third case is looks can be deceiving. So this is a 10-year-old child who is asymptomatic, and he was COVID positive. That's why the X-ray was done. And after looking at the X-ray, the local pediatrician as well as the child parents, they were apprehensive that what is happening to my child. So based on this finding, just to make them ensure properly, CT scan was done, and CT actually revealed that there were absent lung tissue on the left side. There was rudimentary bronchus was present in the left side. The diaphragm was intact because there was suspicion of congenital diaphragmatic hernia also. So to look at that also, the CT scan was done. So this was a case of pulmonary aplasia. That's why the case name was that looks can be deceiving. And in this kind of cases, CT is very important. My fourth case is, name is, after all, we all need some space to grow. So this is a case of neurofibromatosis with severe sclerosis. So whenever there is a severe sclerosis, there will be asymmetrical volume loss on the one side, which will not allow lung to expand. So for that, we had done CT because before planning surgery, CT scan is required to look at any vertebral anomalies and to look at the pedicle size before start fixing. And you can see that on this image, the spine is almost horizontal. It was very severe scoliosis with lung hypoplasia. So in this kind of cases also, CT is very much needed. This was managed by Dr. Sumit and their ortho team, spine ortho team. And you can see that post-operative surgical correction and child is doing very well. Now the child doesn't have any exercise fatigue quality and he's doing very good. Last case, Dr. Shruti already presented, getting rid of the obstacle ASAP. So that was the case of that bronchus plastica, which I am not going to detail. But just want to mention to you that CT can give you exact localization of the obstruction, which is very important. And so to conclude, CT is the investigation of choice in a case of unilateral lung hypoplasia. And with the appropriate use of CT and knowledge regarding this rarer entity, CT can help us in planning correct management, and do not be hesitant in case of indeterminate cases. Thank you for your attention, and I would like to thank you all the teams. Thank you, thank you.
Hiren, I was wondering, that was hooting for you or for us to stop so that we can eat food? So since none of my co-authors are here, I present on everybody's behalf. I need to thank the inputs of Dr. Anaita Udvadia Hegde and Dr. Shruti Bajaj for this case. Now, this was a 6-year-old female child with 3 episodes of severe pneumonia. This was a child who was being treated at Banaras. The first pneumonia was at the age of 2.5, the second at 4.5, and the third at 6 years. The third episode, which was on November of 21, presented as an acute onset breathlessness with hypoxia, hypercarbia, and this child required ventilation for about 14 days. It was really difficult to extubate this child. So though it was labeled as pneumonia, probably there was something else which was presenting, because the child had an acute onset of respiratory distress. The child had received antibiotics, anti-tubercle therapy, and a detailed workup was done which was not contributory. And they sent a genetic testing for a respiratory clinical exome for recurrent pneumonia. Child required home oxygenation and was discharged on home oxygen, and that's how the child came to SRCC for second opinion. Born of a non-consanguineous marriage, first sibling being normal, 32-weeker, NICU stay for a week, but uneventful NICU stay. The child had feeding difficulties in the first 2 years of life and had frequent falls. At the age of 2 years, this child had come to Mumbai for a workup for his hypotonia, where an EMG nerve conduction CPK was done, and a clinical exome was sent, which drew a blank. And there were no other issues in the sibling or any other family members. The child intellectually was normal. So on the third centile for weight and height, the child had a head lag, normal intellect, had a nasal twang, had torticollis, and would prefer to sit upright, also had exaggerated lordosis, had a left pectus excavatum, had weakness of the proximal and axial muscles, a positive Gower sign, and a broad-based waddling gait. The other systems were normal. This was the child's CT, which showed bilateral lower lobe and the right upper lobe involvement, something suggestive of a chronic lung disease of unknown etiology. Now, these are the images of the child. You can see clearly this child had a head lag, but all other milestones were normal. The child was walking but had a waddling gait. You can see the hyperlordosis that this kid had, and you can also see the amount of torticollis this child had. So our clinical impression was that this child has some neuromuscular disease, which is possibly causing the child to have a chronic lung disease. Now, at this point of time, because when the child came to us, the genetic workup had already been sent from Banaras, we spoke at the genetic lab. And what we did mention to them about these features which we found the child had of the neuromuscular disorder. So we rectified the history. So it's extremely important that we give a proper phenotype to get an accurate result from a genetic lab. Because what was earlier sent was a respiratory clinical exome, and we would have drawn a blank if we would have stayed with that history. So we thought of some myopathy or a dystrophy which was causing it, and when we got the genetic report, it reported as a Selenon-related myopathy. Now, Scpn-related myopathy is a mutation in the selenoprotein gene which results in a myopathy and which can present with head lag. So when you see a child with head lag, early onset axial muscle weakness, rigidity of the spine, early and life-threatening respiratory insufficiency, and a relatively slow course of a muscular damage. So when you have such a kind of a clinical scenario, one needs to think of an Scpn-related myopathy. 4 different variants have been described with the Scpn-related myopathy, but they are now considered to be a continuum. So earlier it was thought to be a rigid spine myopathy, a Mallory body-induced myopathy, but they're all now thought to be as one entity in a continuum. And the reason why it causes a myopathy is probably the calcium homeostasis in the muscles is affected because of the mutation in the Scpn gene. So how do you approach such children who have a neuromuscular disorder? So first important is to look at them clinically, ask them about their cough reflex. If the cough reflex is weak, you are heading for a problem. You should ask for the nature of cough. If these children have wet cough, probably they're getting recurrent infections. Look for scoliosis. An increasing kyphoscoliosis can cause, again, a respiratory insufficiency. Do an ABG. If you have a high PCO2 and hypoxia, these are again children who are getting into a respiratory problem. Spirometry should be done, and it should be done yearly. And if the vital capacity is less than 60%, that is a predictor of sleep disordered breathing. And therefore, if you have a vital capacity less than 60%, and if you have symptoms of nocturnal hypoventilation, then your vital capacity will be, if it's less than 40%, you would likely to have symptoms of nocturnal hypoventilation. So if you have these kind of spirometry findings, or if the child is non-ambulatory, you need to follow them up annually. And if you probably need to do a sleep study and institute NIV early to prevent respiratory insufficiency. So in our child, we could not perform spirometry. We tried, but the child could not cooperate. ABG did show hypercarbia and hypoxia. We did a polysomnogram. And if you see here, you can see that the child's sleep pattern is completely distorted. If you see those blue lines on top, that's what the REM cycle is, and they hardly had any REM sleep. And if you see the total sleep time, only 69% sleep efficiency. Child had a PCO2 which lasted for more than 25% of the total sleep time. And the AHI also was significant, was 8. So this child was started on BiPAP, oxygen support, physiotherapy, genetic counseling was done, annual flu vaccine should be given, and advised a regular follow-up. So think of a neuromuscular disorder in children who present with respiratory insufficiency in the presence of signs like a head lag, nasal twang, muscle weakness, or a rigid spine with or without a kyphoscoliosis. Respiratory disease progression is a major cause of death. So monitoring lung function by spirometry and a sleep study can help delay this progression. And we need to do appropriate phenotyping to get good results from genotyping. Thank you very much. The next speaker, please.
Yeah, good evening everyone. I am Dr. Mandar, intensivist from SRCC Children's. Going to present a series of 4 cases. Came to us as a predominant cardiac presentation in the COVID third wave. So here the COVID played a major role, or it was just a bystander, what we are going to discuss. So beginning with the case 1, say 18-month-old female child with normal birth and development, history of cough and breathlessness for a day, and treated outside as acute myocarditis with IVIG and steroids. There was no clinical improvement and his child was referred to us. Came to us on a 4th day of illness. Child was hypotensive cardiogenic shock with multi-organ dysfunction. LV dysfunction with ejection fraction of 15%. This was the echo on presentation. So immediately the child was started on veno-arterial ECMO support. Ventilation was continued. ECMO was continued for 6 days, and gradually the child was weaned off ECMO support. Post-ECMO, child also had a pulmonary hemorrhage leading to refractory hypoxemia, for which he required high-frequency oscillatory ventilation. Myocarditis workup was negative. Only consistent finding was history of exposure to a COVID case in the family, but the PCR and antibodies both were negative. Child had a sustained recovery in his cardiac function. At discharge, the child had a functioning of around 55%, and child went home with intact neurological status. This is the case 2, 7-year female with normal birth development, history of cough for 7 days, fever, breathlessness, and facial puffiness for a day. The COVID PCR was positive, and child was referred to us with acute COVID infection and ventricular dysfunction. Child, when came to us, was hemodynamically stable, but with elevated lactate, probably secondary to cardiac dysfunction. The ECG was very peculiar. I'm sorry for this animation problem. The ECG was very peculiar, which showed tall P waves, very low amplitude QRS complexes, and intermittent PVCs were there, and there was very poor progression of R waves in the precordial chest slits. The echo showed a dilated chambers with poor LV contractility of 25%. Had a elevated cardiac injury markers, and this child had a both PCR as well as antibodies positive overlap. So child was supported with milrinone and methylprednisolone, and IVIG was given. Clinical improvement was there, but function improved very marginally, up to only 35%. This was at discharge. So on follow-up, the cardiac MRI was done, which showed, apart from the signs of acute inflammation, there were changes of chronic scarring also. So the genetic was sent, and it has come as arrhythmogenic right ventricular cardiomyopathy. So this child is still under follow-up, and the heart functioning is still borderline. Moving on to case 3, was a 3-month-old male child with normal birth and development, had an acute history of viral prodrome for a week and excessive crying for a day. Was in shock at the referring hospital, comes to us in a cardiogenic shock. Intubated, had a bedside echo, showed a dilated chambers with functioning of only 20%. This child had a PCR and antibody both positive. Vitamin D deficiency was there as a part of a cardiomyopathy workup. Elevated cardiac injury markers as well as raised ferritin and D-dimer. So was supported with inotropes, treated with methylpred and IVIG. Showed a significant clinical improvement, was extubated on day 5. Recovered LV function of 50% at discharge and went home with a normal sinus rhythm. So this was the echo at discharge, where you can see the good LV functioning. Case 4 was a 3-year-old male child, normal birth development, history of vomiting and lethargy for 2 days, generalized seizure for a day, and reduced urine output for 1 day. Child comes to us with a bradycardia, heart rate of around 30 to 40 per minute in a low cardiac output state. So immediate transcutaneous pacing was done. Temporary pacemaker was inserted with a heart rate of 100 per minute. Cardiogenic shock was managed, supported with fluids and inotropes. This child had a COVID PCR negative with COVID antibodies positive. The ECG showed features of complete heart block. Echo showed normal functioning. Elevated cardiac injury markers and MISC markers were also high. So this was assumed to have an inflammation, isolated inflammation of a conducting system. Methylpred and IVIG were given. Plan was to, there was a thought whether this child will need a permanent pacemaker or not, but with these measures, child showed improvement. Gradually the pacing was weaned off. Child was sent home in a sinus rhythm with a heart rate of 100 per minute. Now I pass on mic to my co-speaker, Dr. Sen, to summarize and give the concluding remarks.
Thank you. Good evening, everyone. So these 4 cases shows us the different spectrum of COVID, and when you have a cardiac presentation, it's very difficult to differentiate between whether it's a de novo COVID-related cardiac involvement or whether it's an acute decompensation with an underlying cardiac disease. So the first patient did not have any RT-PCR or antibody positive, but there was positive family history, and the other 3 either had RT-PCR or antibodies positive. And you can see from these 4 cases that we had patients differentiating, presenting with either stable hemodynamics or in cardiogenic shock. Some required minimal support, and some even went for ECMO support. And the spectrum is very varied, ranging from myocarditis to a conduction defect to a chronic cardiomyopathy. So if you look at the first case, the baseline and the pre-discharge, you can see obviously there's complete recovery. So this was COVID-related MISC type of a presentation. This patient did require ECMO support, but luckily on follow-up, the kid is absolutely normal. The second case, unfortunately, was the first presentation of an underlying cardiomyopathy, and the child decompensated with the COVID, and that's when it was diagnosed. Although the history was very short, when we did the genetic workup, we have a ARVC diagnosis. Echo-wise, this was an LV non-compaction, and this patient ultimately will require a heart transplant, although right now is stable on medication. The third case, again, luckily for us, recovered completely during the hospital stay and is now off all medications. And the fourth case was interesting because at one point we were thinking the child will require a permanent pacemaker, but just with 3 to 5 days of waiting with the steroids, the child had complete recovery and is now a normal kid. So cardiac involvement is not uncommon. We all know that it can happen either in acute COVID or in MISC. We have to have a high index of suspicion for an underlying cardiomyopathy if your cardiac function doesn't improve with the MISC treatment. And it's a bit difficult to differentiate at initial presentation, but as the days go by, we do get to know which one it is. And the dilemma remains whether we treat every patient who comes to us during the pandemic as an MISC or whether, I mean, the question is, do you give IVIG and steroids to these kids when they come in cardiogenic shock, or do you treat them just as a cardiomyopathy? Thank you.
Good day, everybody. I bring to you a 5-year-old child. Disease spans last 3 years. Since 2018, 2017 was the first time that this disease was discovered and described. Referred 5 months back to us by Dr. Vibhor Borkar, our pediatric gastroenterologist, and with his permission, we are managing the child today. This child was born at 3.2 kg birth weight, was growing normally until the age of 11 months when she first had episodes of bloody loose motions. She recovered with symptomatic treatment, but after an asymptomatic period of 7 to 8 months, she developed this asymmetric edema only over the forehead and periorbitally, was given steroids, and again remained asymptomatic for some time. But in 2020, her condition deteriorated. She needed admission once for albumin transmission. At this point, her urines were normal and fecal calprotectin rose to more than 800, obviously pointing towards protein-losing enteropathy. She was treated symptomatically, and in 2021, her condition deteriorated even further. She required almost monthly albumin infusions, and her serum albumin came down to 1.1, never rose above 1.5 even after albumin infusions. She had persistent hypogammaglobulinemia, repeated infections, and her antiphospholipids came normal. But what struck us was this big thrombus that was sitting at the junction of superior vena cava and right atrium. And on further investigations, there were multiple thrombi in the mesenteric and pulmonary vessels. She was again treated symptomatically, and various other causes of protein-losing enteropathy because of these 3 mechanisms were ruled out. She was extensively investigated, and there was no diagnosis. And at this time, with this gamut of problem list and a prothrombotic state, and in this condition, she was referred to us. We had the entire basket of investigations and the child in front of us. Her genetic test had already gone. So what could we do? We could just try to find this in the medical literature if we could. And we did a search, but all differentials that were ruled out was coming. And this is my first message to the room across, that if you need to find something in medical literature, you need to search smart. By just tweaking and putting early onset over there were only 3 results. And we had this clinical diagnosis of CD55 deficiency even before this genetic report came in to corroborate our diagnosis. This was Chapel disease, where complement CD55 deficiency causes dysregulation in the complement pathway, leading to a persistent state of hypercomplementemia, leading to thrombus formation. And it is supposed to be a monogenic cause of primary intestinal lymphangiectasias. There is malnutrition, and of course, all the symptoms that were described here was in the phenotype of our child. But after this initial deja vu of diagnosis, what? The anti-complement therapy, eculizumab, was not only not available with us, but to procure us was very, very costly. And so we went into clinicaltrials.gov, where all the clinical trials with drugs is listed. And to our delight, we found that poslizumab, which again works in the same mechanism, was listed there. We emailed to Regeneron, the company responsible for this trial, but to our dismay, we got a reject. Why? Because this drug could not be made available in India. And we were again stuck. So we thought of seeking help. And whom did we ask for help? Dr. Ahmed, who has worked maximally on this, discovered this disease, working on the treatment, and has 11 in his case series. And he gave us a 2-hour Zoom session with parents in the view. We walked away with 3 messages, started the child on steroid, and since last 5 months, she's not needed albumin transfusion. He prodded us to start eculizumab compassionate registration, but then we got rejected for the same reason that it was not available in India. But the best thing that happened was he talked personally with Regeneron, and we reapplied there. Last week, we've got a mail saying they're trying to act on it. But why this case today? Not to describe the very rare disease which was genetically proven, but simple facts like you must have a clinical diagnosis before you go on to do a genetic test that will help the lab to find your needle in the haystack. Efforts should be made on a national level to get at least some of these life-saving drugs in India so that our kids can register for these kind of international drug trial. Last but not the least, medical care of these diseases need not be personal, intra or interdepartmental. It can be global across the continents, as COVID has given us this virtual single medical fraternity today. Only if we go ahead to do some efforts on this line. Thank you very much.
Thank you so much. And that was a good grand finale. Now I request my judges to come here, and I want to, all 3 of them, Dr. Sane, Dr. Ajit, You can, of course, if you have some questions, of course, sorry about that. Any questions, please?
I just want to make an observation that in the last 2 cases, this is a time when more and more of us are relying on genes and not genius to solve difficult cases. So the most important point was that, as we said, search smart. Time and again we see that we ask with the wrong phenotype, we ask for a clinical exome, and we come out with such irrelevant results. So the most important take home I got from the last 2 cases was that you ask the right questions and give the right phenotype. That's when you get the right answer from an exome. And that was just an observation, not a question. The other observation I wanted to make was that I think we are seeing the same spectrum of cases that we used to see prior to COVID, except that now they are low spectrum plus COVID positive. I don't know what all of you feel.
Any other comments, any questions? No. So, Dr. Ajit and Dr. Sudhir, Dr. Prakash Vaidya. I think we all need to give a huge round of applause to these wonderful judges that we have had, who have heard us through. And I would love to hear from you anything that you would comment, anywhere where we could be better, any of your comments, please.
I think I just loved this idea. I loved this idea that you have multiple cases, 3 to 6 minutes, and I'm sure I'm going to replicate in my city and my institute. Thank you very much, Indu and Raju and everyone. Thank you.
It was an amazing spectrum and bouquet of cases, but sometimes I think it's a little too much in a short period of time. That's all.
I think in a fusion restaurant with the grand ambience, this was a wonderful fusion of clinical plus carnival. We really enjoyed it.
Can I request Dr. Umali? Dr. Umali. So Dr. Umali, of course, everyone knows, and it's an honor to have her honor one of my judges. Can I request you to present this token of appreciation to Dr. Prakash Vaidya? Thank you so much, ma'am. Dr. Taral Nagda. Dr. Taral Nagda is an entity, and you know, everyone knows about him. Can I request you to present it to Dr. Ajit Gajendra Katkar? Dr. Paresh Desai, is he around? He is one of the, always present face at the SRCC, ever smiling. Can I request him to present a moment to Dr. Sane, please? Thank you. Thank you so much. Thank you so much. Absolutely. While we work on the final results, the food buffet is open. The drinks menu is also there, but you can help yourself. I wish everyone from the tables to hand over their choices of who's first, second to Dr. Amin. And we will look after what the judges have to say. And in no time, we will come out with the gifts. Thank you so much.